On a more formal note, the ITI is a global, independent, scientifically independent, non-profit organization for professionals in implant dentistry. And this is something that the ITI and Sepa share. We also share the common purpose on our respective sides of engaging and inspiring the entire global dental profession to strive for excellence in the implant therapy care that we provide for the benefit of our patients. And therefore, ITI and Sepa are very happy to be here together at the World Symposium, and we see from the ITI side this cooperation as a very important part of fulfilling our mission and supporting that mission to serve dentists through a growing network of lifelong learning. So now I'd like to hand over to the Sepa president and welcome Sepa here very warmly to the World Symposium officially.
Thank you very much, Charlotte.
Pleasure.
Thank you, Charlotte, very much for your warm welcome. Congrats to the ITI for this fantastic World Symposium. Everyone can tell that it's been a success, and we can see the excitement of dentistry and the way it's improving. From the Sepa side, thank you, ITI, for trusting us. We work intensely and tirelessly to provide the diffusion of dentistry, highest quality, through Perio, impacting dentists in Spain, but throughout the world. So it's great to be here. We're going to have a very intense and interactive session. Many more people are expected to come, and sure it will be. But we are starting with a topic which I think is of clear help to clinicians, and is the way we approach peri-implantitis. We are aware of the limitations of the surgical treatment of peri-implantitis, and so we have designed a session which includes the so-called non-surgical therapy or flapless approach. So for the ones staying, you will see that you will benefit from this very much. Next to, or after the topic, we'll be discussing on bone regeneration. We'll be discussing as well on immediate implant placement and delayed soft tissue augmentation. So it's going to be, I'm sure, very positive for the ones staying. And please, the idea of Sepa is always to be interacting with the audience. So this is the way we're going to handle it. Ana Molina and Beatriz de Tapia, both periodontists from Madrid and Barcelona teams, are going to be starting, but then after that they'll be moderating, and they'll be giving you the microphone so you can ask as many questions as you wish. And you can even interrupt us when giving the lectures. So Ana and Beatriz, whenever you're ready, they are part of the Sepa board members. They are well-known periodontists in Spain, and they participate in the European workshops of perio as well, particularly the one related to peri-implant diseases. So the high quality of the lecture is ensured, and you'll be noticing it. Okay, so whenever you're ready, the stage is yours. Thank you very much.
So thank you all for coming. We know it's a great effort after the amazing party that we had last night to be here at 8:30 in the morning. So we are extremely grateful and extremely happy to be here sharing this joint session in between Sepa and ITI. We've been working together for many years, and it's really an honor to have this slot of time in the Congress, which has been so successful. So we are really looking forward to make worth your time and to make worth this session for you, and to share with you some insights that will help you maybe on Monday in your clinical practice. So let's start, Beatriz and myself, talking a little bit on how things have changed in the treatment of peri-implantitis in the last 10 years. It's nothing new for all of us. The dental implant placement has experienced a global increase in time. In fact, we are more than 5,500 people here joined by implant therapy. And even though this prevalence has increased significantly, and in fact, we have estimations that say that in a couple of years, 1 out of 4 patients that walk into our offices with a missing tooth will have one implant in their mouth. 1 out of every 4 patients with a missing tooth will have an implant. And this is great and is normal because implants are a fantastic tool that have changed our practice in dentistry. They are a wonderful tool for the rehabilitation of missing teeth in terms of function, and also we do things right in terms of aesthetics. However, whenever we have these amazing figures on survival of implants, more than 95% at 5 years, we tend to overlook that whenever we are talking about survival, we are not talking about success. That's not the same. Survival means that the implant is present in the mouth, but success means that it's present in a healthy situation which is perfectly compatible with the life and the function of the patient. And that is not that frequent. We may face several complications in clinical practice with dental implants, some of them of biologic origin, which are mainly the peri-implant diseases. Also technical, we sometimes have to deal with fractures of the implants, of the prosthetic components, and for sure aesthetic complications. Today in the session we're going to focus on the biologic complications, specifically with peri-implantitis, which according to the most recent data that we have and the most reliable one, affect 1 out of 5 implants. 22% of implants will experience peri-implantitis. So all in all, we have a very common tool in our dental practice with a very frequent complication that unfortunately is not easy to treat. Peri-implantitis is the main cause for late implant failure. It means for explantation. Approximately 83% of the implants that have to be removed from a mouth are removed due to peri-implantitis. And whenever we decide whether to explant or not the tooth, one of the main indicators that we may have is how these implants have responded to therapy. We have a very important marker, which is inflammation in terms of bleeding on probing, that will give us a lot of information on how this implant will behave in time. We tend to say in the frame of scientific evidence that bleeding on probing around implants have a very high positive predictive value and negative predictive value. What does it mean? It means that if we have bleeding on probing in more than half of the supportive peri-implant care visit for 2 years, that means that for sure we have 100% of chances that this implant is experiencing progression of a peri-implant disease, either mucositis or peri-implantitis. However, on the contrary, if we do not have inflammation around a dental implant, in less than 20% of the visit during 2 years, this means that that implant, those surrounding tissues are stable. So this is very important to bear in mind because we will look for implants which are not inflamed and which do not bleed. We have been working for many, many years trying to convince our patients that bleeding around the gums, around their teeth, is not normal. But now, us clinicians tend to consider normal that an implant which is bleeding, and it is not. When the patient comes to the clinic and we ask him, do your teeth bleed when you brush? Yeah, a little bit the normal. No, it's not normal. If your teeth are bleeding, it's because you have gingivitis, blah, blah, blah. When we talk, even among ourselves, among clinicians, how were the implants of Pedro? Oh, they were fine, perfect. Just a little bit of bleeding, but they were perfect. No. They were not perfect. They had mucositis. And if we keep on seeing that mucositis in time, we will have peri-implantitis. And peri-implantitis, unfortunately, is not easy to treat. Just a couple of years ago, we held in Spain the workshop for the prevention and treatment of peri-implant diseases, the EFP guideline that some of you are aware of this consensus document. And one of the main and most surprising things that we found out in this consensus is that we do not have a gold standard for the treatment of peri-implant diseases. The treatments that we do have in our hand have very poor results and very, very low predictability, and there is a high tendency towards disease recurrence. But before putting the bandage before the wound, as we say in Spain, Bea, which is the way that we treat, that we have been treating peri-implant diseases, peri-implantitis specifically?
Well, the need of treating peri-implantitis, it's a fact. Key differences impacting care of treatment of peri-implantitis and treatment of periodontitis have been identified. However, the theoretical foundation of the treatment of preimplantitis is based on those successful approaches of periodontal therapy. So, a step-by-step approach have been proposed, as we used to do in periodontitis. This stepwise approach mirrors the one of periodontal therapy, and some interventions are very similar. First step that we used to do is non-surgical treatment. The main objective of this step is to arrest inflammation and to disrupt subgingival biofilm. In addition, some procedures attending to diminish supragingival biofilm and attempting to diminish risk factor control are also part of this step. The reason for going through this step by first time is mainly, on one hand, we are going to see that a huge percentage of patients can benefit of it, not only in terms of diminishing inflammation, but also in terms of disease resolution. Anna will give us later more information about this, but barely 0.5% of the patient can benefit of it and avoid going through more complex stages. Not only this, you will see that most patients with preimplantitis also present concomitantly periodontitis that needs to be treated. And last but not least, in those cases where we finally need to go through a surgical step, we are going to go through it in a later time when our patient probably has a better biofilm and risk factor control. After doing our treatment, it's mandatory and it's very important to assess the outcomes. Reevaluation, it's mandatory. We need to assess if we have been able to arrest the disease, to get to the disease resolution, to decide whether to enroll our patient in a secondary prevention supportive periodontal care or whether to go through further steps in the treatment. Excuse me. The recent published clinical practice guideline suggested to wait between 6 and 12 weeks after treatment to do this reevaluation. However, most studies found improvements in probing pocket depth up to 1 year after the therapy. So, in those cases where we didn't reach those endpoint therapy goals, it should be prudent to wait a little bit longer if we are seeing that there is a clear improvement in inflammation and in probing depth reduction. So, which are these therapy endpoints that we need to achieve after our treatment? First of all, a residual probing pocket depth at most of 5 millimeters. This together with absence in bleeding on probing, that means absence in inflammation. We won't register bleeding on probing as a dichotomic value anymore, like we used to say. It bleeds, it's inflamed, it does not bleed, it's not inflamed. Instead, we will use a severity degree index, as is this one described by Mombelli in the 80s, that is called modified bleeding index. And we will consider health when we have, at most, one single bleeding point of the 6 out that are registered that bleeds as much as modified bleeding index 1. This means an isolated visible point of bleeding. We will consider health this. Why? Because this will include all possible damage to the tissue that can be done while probing for an excessive pressure, or in those cases where when there are difficulties for probing angulation due to the prosthesis morphology. And this will avoid a lot of false positives. So, well, we've said that after non-surgical treatment, we will do our reevaluation that is mandatory, and then we will decide to enroll our patient in a supportive care treatment that is a very important step to stabilize treatment outcomes, or in those cases where the disease has not been arrested and we have inflammation and probing pocket depth compatible with disease, we need to go through further steps. And further steps in this case is surgical treatment. It's not the objective of today to explain thoroughly surgical treatment of preimplantitis, but I just wanted to give you a schema of the options that we can have. We can go through an access flap, resective surgery, regenerative surgery, combined surgery, combine surgery with implantoplasty, and of course, combine all these approaches with mucogingival therapy. But Anna, can you let us know or give us a brief information about which is the success rate of this step?
This is what we have been doing for many, many years, right? So how successful were we with this approach? Let me share with you a review. It's not a systematic review, it's a narrative review, but it's based on a systematic search, and it was made by our research group at Complutense University exactly 10 years ago. This is the review that marked the way we treated things when I was a postgraduate student, and I want to share it with you because those conclusions were clear and strong. They included 13 clinical trials in the non-surgical treatment of periimplantitis, in which mechanical debridement was performed in several manners, and chemical biofilm control, either by the use of antiseptics or antimicrobials, was used as a coadjuvant measure. Which were the outcomes of therapy using this non-surgical approach back in 2014? The greatest pocket depth reduction reported in the literature back in 2014, 10 years ago, was 1 millimeter. And I'm not talking about a mean. That was the greatest reduction of all the 13 clinical trials included. Bleeding and probing after therapy was still present in more than 50% of the implants treated. And we have already said how important it is not to have bleeding around our implants. And there were no changes in bone levels at all with non-surgical treatment of periimplantitis in 2014. In fact, the conclusion of the paper and the recommendation, and this has been taken literally from the paper, is that it seems that non-surgical therapy of periimplantitis is not effective in disease resolution at all. Therefore, they recommended to consider going for advanced therapies, including surgical interventions for the treatment of periimplantitis. So 10 years ago, we used to do non-surgical therapy to reduce the inflammation of the tissues, but we were almost going for a second step of therapy that was surgical in almost all cases. So, if that was the state of the art back in 2014, how can we explain that nowadays, with these defects, we can have these changes? Or with this initial defect, we can have this final situation just after submucosal debridement, implant decontamination, antibiotics, and local antiseptics. How could we explain those results if the literature back in 2014 said that it was impossible to obtain this? Is because this has been done by very skilled clinicians, such as the speakers that we have today? No, not at all. This has been done by my second-year students at the postgraduate program for odontology and implant dentistry. They're amazing, they're fantastic. Mark their names and their faces because you will hear from them. But they have been receiving training for just 1 year, and they are able to get those amazing results. So we might be doing something different. What does the literature says now in 2020s? Well, one of the first publications comes from the group of Professor Juan Blanco in Santiago by Antonio Liñares, and it was a retrospective case series, including 18 subjects and 25 implants that were subjected to mechanical debridement with the concomitant use of systemic antibiotics, in this case with metronidazole and prosthesis modification when needed. What did they found? They found a mean pocket depth reduction of 4.6 millimeters. Remind us that back in 2014, the greatest was 1 millimeter. Now the mean is 4.6 millimeters, 4 times more pocket depth reduction. And they also observed that they got bone level changes of 2.7 millimeters. Back in 2014, we said that changes in bone level were not detected at all. This same group, just a few years ago, has published an RCT in order to demonstrate that this is not just a coincidence, a few cases that went well, but this is something that is predictable, in which they compare the use of antibiotics versus a placebo as a coadjuvant for this mechanical debridement. And again, they found out that these results were predictable, that we had reductions in pocket depth of 2.5 millimeters, in full mouth bleeding scores of 20% after therapy, and radiographic changes of more than 2 millimeters. And these fantastic clinical results were obtained. This, you may say, okay, this is obtained in Santiago de Compostela under Professor Juan Blanco group of research because something in the water is better than in the rest of the world, but it is not, because our professor José Nart also published back in 2019 a case series demonstrated that in Barcelona you can also get those amazing results. They perform mechanical debridement, in fact it was performed by himself, together with the use of systemic antibiotics in 21 patients, and they obtain a similar pocket depth reduction of 3.7 millimeters, radiographic changes of 1.3, slightly worse than in Santiago, Jose, you gotta improve, and reductions of bleeding and probing of 20%. The survival rate was quite high. After 12 months, only one implant was lost, and disease resolution was estimated to have been obtained in 40% of the cases. The definition for disease resolution was quite strict. Only one spot of bleeding wasn't considered non-disease resolution. Very recently, also our group in Madrid has demonstrated similar results in a case series with a wider sample, up to more than 300 implants, in which mechanical debridement with the concomitant use of several antibiotic regimens obtained reductions in probing depth of 3 millimeters as a mean, bleeding on probing again under 20%, and radiographic bone changes of 1.2 millimeters as a mean. And which is more important, and something I want to highlight from this study from our colleague Ana Carrillo, is the following. They obtained disease resolution in 55% of the implants, because some of them still have some bleeding spots or some pocket depths greater than 5 millimeters. But out of the 330 implants treated, only 5% had to go through surgical therapy. So 10 years ago, we were almost condemned to have surgical therapy in all our implants with peri-implantitis, and nowadays, now in 2024, only 5% of our patients with peri-implantitis might undergo surgery. That's a huge improvement. And again, those fantastic clinical results were reported. And you will ask, okay, but the therapy, debridement, antiseptics, antibiotic, that was used also back in the 2010s. So where is the secret?
I was hearing you, Anna, and I was getting impressed again with all this information. How can we explain that like 6-7 years ago, we were considering non-surgical step as a previous step for preparing the surgery? We thought that every peri-implantitis should go through a surgery. And nowadays, we're obtaining this type of results with non-surgical therapy. What has changed? What do you think? I can assure you that we didn't change our curettes for magic wands. So what happened here? Well, the key, the clue, maybe the explanation is that we are talking with the same name about different procedures. What does it mean? In the classical approach, the main objective of this approach was the biofilm disruption. That's it. By mechanical methods. No attempt of debridement, no attempt of excision of the inflamed tissue. And what do we do now? Our objective is different. We try to eliminate, to remove all those peri-implant inflamed mucosa, doing like a careful detachment of the periodontum to be able to gain access to the bone walls and to the implant surface to improve its decontamination. As you can see, we do a thorough curettage of the area. We remove all this inflamed tissue, and we leave the healthy peri-implant mucosa in its place. As you can see, these pictures are very nice because we can see how we have gained access. We can see even the bony walls. And we can maybe call this approach as a minimally invasive flapless approach. No, Anna, what do you think?
Yeah, absolutely. In fact, you will find it like that in the literature. This is also called surgical flapless approach for non-surgical treatment of peri-implantitis.
So, which is the main benefit of this shift in the approach, this paradigm shift? Well, first of all, we need to talk about decontamination. Eliminating all this inflamed tissue, as I have said before, give us much more access to the implant surface, and we can access much better. And last but not least, the most power of this approach is the blood clot stability. This enhances wound healing and is the first step for spontaneous regeneration. So, which steps should we follow to accomplish this approach appropriate?
So I would like to go through all the steps of the therapy with you. I will kind of do a mix because all those papers that I have shown you from the group in Santiago, the group in Barcelona, and our group in Madrid, they do a slightly different things, but more or less it's the same. So I have kind of tried to mix them all to give you a recipe on how to do it in your clinical practice on Monday, okay? So first of all, we need to have the better access possible to the implant surface. So whenever possible, please remove the prosthesis because you need to access to the implant surface to the better of your capability. If it is not possible, we can also do it without removing the prosthesis, but it will be much more easier if you take it out. So that's important also when we plan our implants to do a screw-retained prosthesis instead of cemented ones, so we are able to remove them if needed for the treatment or even for the assessing of the healthy status of our implants. So whenever possible, we are going to remove the prosthesis, and whenever needed, we are going to modify it to allow for an adequate oral hygiene access, but we will talk a little bit more in depth about this later on. So first, access to implant surface is compulsory. Then we're going to do curettage. It's not a scaling and root planning. It's not the same way as we treat teeth. When we treat teeth, we want to remove all the biofilm and the calculus for the implant surface without damaging the inner part of the pocket. But in here, we do not care that much about the inner part of the pocket. In fact, we are going to do a minor mucosal removal of the inner part of our peri-implant pocket. And in fact, we're going to get to the bone. With our curettes, we're going to detach the mucosa from the bone up to 2 to 3 millimeters. Why is that? Because we know that these lesions respond totally different to non-surgical treatment. They take longer to heal because they are not the exact same lesion as we have around teeth. In fact, we have seen in histological studies that the inflammation in the soft tissues around implants reaches the bone, which is something that never happens around teeth. We always have a connective tissue wall which is healthy that prevents that infection and that inflammation in the soft tissues to reach the bone. It doesn't happen around implants. It's a wider lesion that progresses faster and to a greater extent. So we have to remove all those tissues. Do not be afraid at all to touch your implant or to touch your bone with your curettes and your ultrasonic tips. In fact, there is no need to use very fancy titanium or plastic Teflon curettes. We want to use steel curettes because whenever you have a bone defect, you have to go with your strongest weapon to fight against this inflammation, right? So we are going to do curettage, not a scaling and implant planning, right? Let's see some videos that have been kindly taken by Bea in the clinical practice on how we debride first with our normal ultrasonic points, nothing fancy, nothing special, and then how we remove the granulation tissue with our curette, detaching the tissue surrounding the implant and the bone up to 2 to 3 millimeters. You will see how we remove this granulation tissue. This is maybe the only good thing about peri-implant defects is the way that the granulation tissue is less attached to the implant surface and to the bone than the granulation tissue around teeth. It's way more easier to remove it, thankfully. Yes, you have some light in all these nightmares that we have in the clinic, which are peri-implant diseases. So once we have removed the granulation tissue and we have gained adequate access to the implant surface and to the bone, we're going to try to decontaminate to our better capability the implant surface. And for that, we can do irrigation with several things. We can either use chlorhexidine, 0.12%, or hydrogen peroxide at 3%, or both, not combined, one at a time, okay? And if you use peroxide hydrogen, it is recommended to then rinse with saline in order to just finish its activity, okay? So you can either use through your tip of the ultrasounds, such as they do in Santiago de Compostela, or you can do irrigation with a syringe if you don't have an ultrasound device that irrigates through the system. On top of this chemical decontamination, we can use air policing. We are working subgingivally, so we will always use erythritol or glycine. We cannot use bicarbonate subgingivally, okay? And this is not compulsory to be done. It's recommended if you can, but you have to take a special care to prevent emphysema in these lesions. You have to use an adequate tip, which is specifically designed for its use subgingivally, especially if we are working in pocket depths of more than 5 millimeters. We have to take a special care to be working very parallel to the surface of the implant. So if you are not able to remove the supracrystal or the prosthetic components and gain parallel access, don't use it. And another recommendation is that if your pocket depth goes beyond the mucomucosal junction, what would be the mucogingival junction around teeth, but we call it mucomucosal junction around implants, don't use it, because you will getting into a territory of very loose tissues in which, even though you go parallel to the implant surface, the air may induce an emphysema. So be careful if you don't have attached tissues beyond the pocket depth, okay? After that, we can add some adjuvant measures. Almost all these protocols that I have showed you from the 3 treatment groups use the coadjuvant addition of an antibiotic. It's the most common protocol is to use metronidazole, 500 milligrams every 8 hours for 7 days. But that last case series of more than 300 implants that I showed you from our group in Madrid used different protocol combinations. It was done in the private practice, so it was kind of flexible. And for some patients, they prescribe metronidazole. Some others use azithromycin, 500 milligrams, 1 per day for 3 days. And some others, amoxicillin. And in more than 20% of the cases, they did not give any coadjuvant antibiotics at all. And still, they got those very nice results that I showed you. And we will also complement the mechanical biofilm removal of our patients with chemical plaque control for 2 weeks after therapy in the form of a rinse of chlorhexidine twice per day for 14 days, or the use of a chlorhexidine gel. That's up to you. And last but not least, and something which is extremely important and mandatory, we have to do a very thorough close monitoring of the cases. As Bea told us at the very beginning, the clinical practice guideline says that we have to reevaluate the results of therapy around implants a little bit later than around teeth, because they take longer to heal. So we will do our first clinical reevaluation 2 months after therapy, and in this clinical reevaluation, we want to check that inflammation has been controlled, that there is no bleeding, no suppuration, and there is a reduction in pocket depth. But probably we won't see changes in bone levels after 6 months, maybe early at 4 months, but the recommendation is to take your control X-ray at 6 months in order to start detecting those changes in bone levels. Then, for the first year after therapy, the recommended protocol for supportive peri-implant care is every 3 months. And once we have reached the first year, when we have good results and they are stable, we will adapt these intervals to the risk profile of the patient. Maybe they will be still coming every 3 months, or maybe they can come every 4 months or every 6 months. But most probably, we will see our patients for supportive peri-implant care twice per year. So let's focus on 2 specific aspects. First, the role of antibiotics, that I have also mentioned that the most protocols use it, but not all of them, and also the way we modified and when do we have to modify the prosthesis. Bea, enlighten us, please.
So which is the role that antibiotics can play in this approach? Well, there are 2 randomized clinical trials that have been published trying to give us results of the added value of prescribing antibiotics. One of them is performed by the group of Dr. Juan Blanco that is today with us. And indeed, they found an improvement in those patients where the antimicrobials were prescribed. Mostly of them were treated with metronidazole or amoxicillin plus metronidazole. And furthermore, in one of the studies of Dr. Blanco, they showed a radiographic bone gain up to 1.2 millimeters. It's needed to mention that these improvements were especially seen in those deeper lesions, when the deepest side of the implant was analyzed. We need to comment also that even though it's not our usual regimen, recent promising results have been published with the use of azithromycin that has a lower regimen dose of only 3 days. However, the prescription of antimicrobials during this step of treatment is not recommended to all our patients. There is a public health issue standing all over the world that is a major concern, and obviously I'm talking about antibiotic resistance. And there is a clear need of diminishing our prescription of antibiotics to our patients, to those patients that can benefit the most. And of course, we need to don't lose sight of those possible secondary harmful effects, especially those harmful individual effects in the individual microbiome. So we will recommend antibiotics. We will prescribe antibiotics to those patients that have especially deep pockets with especially extensive degree of suppuration and infection, and to those patients that have several implants that are strategically affected and could respond well and could be maintained over time. Talking about the superstructure, do we need to pay attention to it? Of course we do. An inappropriate prosthesis design with too steep profile, with flanks or flaps or closed embrasures, or even when we didn't respect the distance between the prosthesis and the bone crest, can hinder the ability of the patient for oral hygiene. And we know that the biofilm is the main etiological factor of peri-implant diseases. Furthermore, those prostheses that are inappropriately designed can also greatly complicate the ability of the clinician to detect and to diagnose peri-implant diseases. You can imagine how can you parallelize the probe to the implant axis in this prosthesis in the tooth number 4.6. It's almost impossible. And this can limit the capability of the clinician to detect and diagnose peri-implantitis and mucositis, of course, in those early stages where our results of the treatment are much better. It has been described that an emergence angle of our prosthesis higher than 30 degrees increased significantly the risk of developing peri-implantitis, as well as those prostheses with convex profiles. But this does not affect only the risk of developing the disease, but also it hinders and limits our results in our treatment. We have developed a study in our team in International University of Catalonia in Barcelona. I'm happy to see some part of my team here, Professor Nat and Dr. Mozas. And we developed a study trying to assess the impact of an inappropriate prosthesis design that hinder the capability of the patient to clean and to reach the implant sulcus. We have 2 groups of study. Both of them had pre-implant mucositis, and both of them had prostheses that impeded somehow oral hygiene. In the test group, prosthesis was modified. In the control group, it wasn't. What did we see? What do you expect? After 1 month, we have wonderful results for both groups. That's amazing, perfect. Of course, we took off the prosthesis to clean. We made a cleaning. There is a de-inflammation after 1 month. But what happened later? If you see this median plot, you can easily see how the evolution path of the 2 groups are completely different after 3 months. We can see how there is a consistent improvement in the test group, but the control group suffered a rebound. And at 6 months after treatment, we had resolution disease in 66% of the patients of the test group, but only 9% of the patients of the control group. It's important to bear in mind and do the modification, of course, of the mesodistal aspects of the prosthesis, but we shouldn't lose sight of those vestibular and lingual area, and we should also modify and contour all this area for easy and improved patient oral hygiene. Up to here, our presentation, and we would like to give you some straightforward take-home message. First of all, non-surgical treatment, if performed appropriately, can be effective. Flapless approach for the treatment of peri-implantitis is aimed at soft phase decontamination, granulation tissue debridement, coagulum stabilization.
But we have to change the way we do things. We have to use these new approaches because if we use the classical ones, we won't be able to obtain those results. But now we can really change our method. We can treat peri-implantitis with non-surgical therapy. It is effective, and we can get to have disease resolution.
Of course, those local and systemic risk factors need to be controlled, and this is mandatory for the success of our treatment in the long term.
And what is even more important is to have a close monitoring and a patient which is compliant with supportive peri-implant care and also compliant with biofilm removal at home. That is why we have made such an emphasis in the modification of the prosthesis. Sometimes we may have to change it completely, and we have to explain to our patients the importance of investing in a new prosthesis if needed. Because if we cannot clean properly, we cannot remove biofilm, either at home or during supportive peri-implant care, we won't be able to maintain the stability of those results in time. But there is some light. We were kind of desperate back in time with the high prevalence of peri-implant diseases and the low and poor results that we obtained. But let's keep our faith and let's be positive for the future, because those new approaches are coming and there will be more randomized clinical trials coming out in the next years. And we do have tools to treat peri-implantitis. So we thank you all very much for your kind attention, for attending the session at these very early hours of the morning. And that's it. We will have some time to discuss if you have any questions at the end of the session. Thank you. So now we're going to keep on going, talking about how things have changed, and we have changed our therapy in different aspects of the clinical daily practice. And for that, we have Professor Juan Blanco with us. Professor Juan Blanco did his postgraduate program in periodontology at Complutense University in Madrid, and is now the chairman of the perio department at Santiago de Compostela in Spain. He is past president of the Spanish Society of Periodontology, past president of the European Federation of Periodontology, and past president of the ITI Iberia group. But he's current mentor of many. He's a magnificent clinician, an outstanding researcher, and a very good friend. So please help me give a warm welcome to Professor Juan Blanco. Thank you, Juan. Was it keynote?
Sí. Buenos días. Estamos en Sepa. Buenos días. Good morning to all of you. Dear friends, dear colleagues from Sepa, from ITI. It's a real pleasure and a privilege to be here today. Hopefully this, we can call this a symbiosis. I don't know if maybe a dysbiosis, this joint between ITI and Sepa, but hopefully we'll end in a very nice story. Thank you very much for your kind introduction, dear friends. And my topic for today is how can I see the future for bone augmentation, bone regeneration? Can we say that we are in front of some modifications, some shifts in these approaches, or are we still in the same way as in the last decades, let's say 20, 30 decades? Can we have something different? And this is what I'm going to try to deal with you in these 30, 40 minutes. For sure that probably all of us, we have treated our patient with one of these techniques, the bone grafts, the GBR technique with particulated bone grafts, bone substitutes, different kind of membranes, the temple technique, the Curie technique, the different kind of techniques. For sure that all of us, we have treated our patients at least one day with this kind of techniques. And clearly, in the literature, this is perfectly documented and evidence-based with this systematic review, and not only systematic reviews, but also meta-analysis that quantify the treatment, the bone augmentation in these cases. But in this paper in 2014, we can see clearly that there is no indication for that there is no clear indication for all the different kind of defects that we have in our patients, because it's very important to understand that behind all these kind of treatments we have biology. But an important issue is not only to check in the randomized clinical trials, in the systematic reviews with meta-analysis or without meta-analysis, only the success in terms of millimeters of bone augmentation. But also, it's very important to understand that we are with patients, and many techniques or some techniques can have more complications than others. And it's very important for us as clinicians to be skilled in the different kind of techniques, but because all the techniques have a learning curve, and probably in many situations we can have more complications with one technique than with other techniques. But at the end, and the conclusion of this study in 2014 is that we can leave for the clinician some space to decide the technique, the approach where he can feel in a better way to treat the patient and the defect that the patient has in that moment. And clearly, the difference. I'm going to sing now. And clearly, the difference in all these techniques probably is in the biology, because we have to understand that in the body we have two types of regeneration. The physiological regeneration, that this is very important to understand it, that different kind of tissues are able to regenerate by themselves. And one of these tissues is the bone tissue. And this is very important to have and to understand that we are going to have remodeling, and with this remodeling, please, in the first line, please. And in this remodeling, with this remodeling, we are going to be able to obtain this bone augmentation. And clearly, this remodeling is something that takes time. So we have to be aware that, for example, soft tissue takes time to heal, as we saw in the previous lecture, but also the bone needs time to heal and to maturate and to remodel finally in a lamellar bone. And this remodeling, we have to understand that persists throughout the whole life. Of course, with this remodeling and with this, let's say, auto capacity of the bone to grow by itself, there are some defects in the mouth that they can by themselves heal. For example, a very typical defect is the alveolus after an extraction. It's going to heal. Of course, it's going to be modeled and remodeled. This means that we are going to lose some profiles, some quantity of bone, some quantity of soft tissue, but at the end of the story, it's going to heal by itself. Of course, it's very important the number of walls, the location, if it's in a closed or an open healing, etc. And this is going to influence, of course, in the regeneration, the capacity of auto-regeneration of this kind of defects. Of course, it's going to influence in the blood supply and all these kind of biological principles such as bone stability, the stability of the coagulum, as already have just said in the previous lecture, and the availability of the cells that are going at the end to have the capability of regenerate the bone. But on the other hand, we are going to have what is called the traumatic regeneration. or the post-traumatic regeneration. And that means that this defect is going to be bigger than the one that has the own capacity to heal by itself. So considering this, we have to understand that as clinicians, we need, or we have to prepare the body and the technique to allow the body to regenerate finally, in this case, the bone. And we need to do some approaches, some techniques that we need to increment the regeneration. And finally, we are going to need blood nutrients that this comes from the coagulum. We need mechanical stability, such as always in the long bone fractures. And we need time. We need time for the regeneration, and the bigger is the defect, the more time that we are going to need for the bone regeneration. And at the end, for the remodeling, as I have just said, we need time. We need long time, and this is something that I'm going to show you in some cases later on. So what's happening in our mouth, or defects, the etiology of the defects in our mouth? We have different possibilities in terms of etiology, but probably the most important and the most prevalent are the infection and, of course, the post-extraction ones. Not only today the post-extraction teeth, but also the post-extraction defects coming from failure implants. But the question here is if we are not able to treat small defects, because we are very clear, we have very clear, and we are very sure that all of us, we are able to treat defects that are small. But what about these kind of defects? Are we able to treat this kind of defects from a predictable way? Or the other one I'm showing you in these X-rays. After failure of implants, you can see a huge defect in a vertical and probably horizontal defect that we call these defects today a 3D dimension defect. So what can we do to treat these defects? Of course, we need to do regeneration, bone regeneration, and we have to understand what we need. We need bone, of course, but the bone is composed of different parts. And probably the future is to understand that these different parts can be or can come from different parts. And putting all these things together, we are able to finally to regenerate the bone. So, of course, we are going to need a scaffold, a matrix, as clearly we have also in the bone. We are going to need cells, and we are going to need growth factors. And taking all these things together, finally, we are going to be able to obtain the bone that we need. What we have today, what is the best choice that we have today? Clearly is autologous bone, is the autograft, the bone block. Clearly, with an important part of trabecular bone. This is very important because in the trabecular bone is where we have the cells. Clearly, the stem cells are in the trabecular bone. And of course, we need some cortical that is going to stabilize, is going to give us this scaffold that is able to obtain this bone augmentation, or the profile of the bone augmentation that we have to obtain at the end. But of course, when we use this kind of materials, these autografts, we are going to have morbidity in the patients. We are going to have, we need a second surgery place. We are going to have difficulties technically. We are going to have complaints coming from the patient, complication, and sometimes limitation. And of course, we need time to do this kind of surgery and to very well skilled. So here is where, after this introduction, where I'm going to tell you what are the objectives of this presentation. And clearly is to send you a message that probably we are in a new era where we are going to have in front of us different possibilities in the near future to do something different and probably easier. That is this is a very important message, because it's easier for us, but of course for our patients, that considering today the patient-related outcomes, this is very, very important. I'm going to tell you and to talk to you about also well, we need to be very, very well skilled anyway, and I'm going to tell you some tips about the good clinical skill and, of course, the habits that we need. I'm going to show you some clinical cases and finally the conclusions. What is the near future? Of course, to have in mind and to bear in mind that there are this kind of components that we need: the matrix, the cells, and growth factors. This is mandatory to have bone regeneration. And probably the future is going to be in these new scaffolds, and new probably alloplastic scaffolds that can be made of ceramic, can be made of polymerics, or can be composite of both materials. They are going to be 3D fabricated, of course, and clearly these alloplastic biomaterials or these scaffolds are going to be individualized for every patient, and not only for every patient, but also for every defect that can fit perfectly in the different zones of the bone or the maxilla. Of course, that these scaffolds need to have biological requirements and structural features. This is, of course, mandatory also. And with these technologies, through the 3D printing, and probably today with the mill technique, we can obtain these individualized, let's say, bone grafts that we are going to use in the near future. What is the evidence to use this kind of biomaterials? Of course, we don't have enough evidence today to use it in a daily practice, but we have some ideas from the preclinical studies taken in vitro, taken in vivo, with different biomaterials, but not also used as an scaffold, but also as a carrier, where these alloplastic materials can be doped with some mesenchymal stem cells, or also, why not, with exosomes that come from different stem cells. And what we have today, the most, let's say, near or closest to this kind of scaffolds that are prefabricated is these CAD/CAM allograft scaffolds, that they are mill prefabricated. And with these designs, we are able to treat patients like I'm going to show you in a few minutes. And of course, with these kind of materials, there is some literature that support that we can use these kind of materials clinically, such this case series, for example, another case series with a 22 years follow-up or a 5 years follow-up, where the conclusions of these studies is that this kind of biomaterials, these customized bone block allografts, can be used perfectly in our patients with even better or similar to the autogenous bone graft. So if we are able to obtain with another technology that is probably easy to be used in our patients, why we are not going to use them? I don't have any answer to answer this question. Of course, we also have systematic reviews, again supporting the use of this technology, and very recently has been published this RCT comparing the block autogenous graft and with these CAD/CAM biomaterials, these customized bone blocks. And of course, you can see that even sometimes the results are even better with this kind of materials, with better bone gain obtained and also less resorption. So, dear colleagues, I think that we are in front of something that can be used in our patients. Why not are we going to use this kind of technology? Tell me, please. And of course, we are able not only to use these scaffolds, but also what we have today in our daily practice, let's say with cells and also growth factors in the possibility of platelets concentrates, in this case the LPRF. And this technology, we have studied in our university the secretome and the proteome of this kind of biomaterials, and we were able to obtain growth factors and to obtain different molecules in 3, 7, and 21 days. So probably we are not in the last, let's say, PRF product, but probably today we have in front of us a product that can be used in our patient and is for sure to have some added value, as we have recently published in the period 2000, where this product has several functions that can support our treatments, such as the antibacterial, anti-inflammatory effect, the hemostatic effect. They are able to help us in the regeneration, hard tissue, and also soft tissue. And of course, there are important in vitro studies supported by the group of BN, by Reinhard Gruber, telling us that these kind of biomaterials are important controlling the osteoclastogenesis, that is very important in terms of bone regeneration, as you can see in the first paper. And in the second paper, these materials are able to shift the macrophage from the M1 to the M2. That is very important in terms of bone regeneration. But we have today some clinical studies that support that we can use in a good way this kind of biomaterials, such as we are having less exposures of the membrane, for example, of the mesh that we can use, and also from a clinical point of view. So, dear colleagues, we are in front of something that can help us to treat patients like the one you are seeing in the screen, a 70-year-old woman that has no bone on the right side of the maxilla. He has lost her implants. However, we have to give her a new possibility. And the possibility in these patients where there is no bone, we can use this technology using these allografts that are prefabricated and are individualized to the defect of the patient. We install these allografts, we use the LPRF membranes, we use, of course, we cover everything with the collagen membrane, a slow resorption collagen membrane. We have to close everything very gently and, of course, without tension in the lips of the wound. And finally, we are able to obtain very nice results that allows us to increase the bone and finally to rehabilitate the function of this kind of patients. Look at the image in the left, look at the image in the right. After using this technology, very easy to use. In terms of morbidities, very reduced morbidity, very reduced complications. And look before and look afterwards the treatment. So we are able to reconstruct the profile of the maxilla, and finally, according to the pre-design that we prepare beforehand the treatment, we are able to treat the patient with this kind of implants. However, we have to be aware that we need also to have, let's say, good hands. We need to be very well trained and to have good habits to use this kind of biomaterials or to do whatever bone regeneration technique that you use. First of all, we have to prepare our recipient site. We have to do the right incisions. I'm going to talk to you about the incisions later on. We have to do the decortication of the cortical bone. And this is probably not as important as we think, because at the end of the story, every technique that we use for bone augmentation is going to heal. However, it's clearly demonstrated in the literature that the maturation of the bone augmentation of the bone graft is going to be earlier if we go for the cortication. And the reason, the biological reason for going to the decortication to do these holes is to penetrate in the trabecular bone, because there is where these mesenchymal stem cells are, and we are claiming for them to come to the bone. Of course, we need to fix these grafts. These grafts are fixed with different kinds of osteosynthesis systems. Of course, it has to be very well fit to the bone, to the basal bone. It's very important not to have dead spaces. And finally, after treating the flaps and preparing the flaps, where we have to increase the length of the flaps. Maybe sometimes it's very important to have 10 millimeters, 50 millimeters of the extent length of the flap, not only in the lingual, but also in the vestibular aspect. And I have to tell you that probably it's much easier to cover these kind of biomaterials in the lower jaw than in the upper jaw, because in the lower jaw we can mobilize the vestibular and the lingual flap, but in the upper jaw we can only mobilize the vestibular flap. How we do elongate this flap? Of course, we know that we can, that we have several possibilities. One of those possibilities is to cut the periosteum. This is the most known technique to increase the length of the flap, but also we can go for example, free incisions. And in the palatal side, we have to do something, I think, different. We have to move a little bit the incision to the buccal side instead of doing in the maxilla. Instead of going to the palatal side, we have to move the incision to the buccal side, and this will be depending on the height of the vertical defect, as you can see here in this figure. Immediately, in the normal situation, we move to the crestal incision, to the mid-crest, but when we have different heights, different size of heights, we have to move it a bit more to the buccal side, as you can see here. Finally, obtaining flaps like this, where the flap in the palatal side is bigger, is longer. So this allows us in an easier way to close the healing and to close the bone, and to have a better healing at the end. What about the lingual side? In the lingual side, we have probably more structures from an anatomical point of view that can be more dangerous to treat them and to manage them, such as the nerve, the mental nerve, and of course in the lingual side we have to mobilize and to detach these fibers of the myloioideo muscle, and of course to be aware of the glands, to be aware of the vessels, the arteries, and also the lingual nerve, and also the veins that we have in the lingual aspect. And for me, this description of the anatomy of the lingual and the vestibular aspect is very important to understand here on your left, where you can see clearly the different aspects and the fibers of the myloioideo muscle that you have to detach. It's very important to very gently, not with the plate, but probably with the periosteum, in a blunt dissection, we have to go for the detachment of these fibers of the muscle. And with this, we have also, according to this study by Isvan Urban and also our friend Gustavo Avila, that has, they have a study clearly how with these three maneuvers is it possible to increase the length of the lingual flap in a better way, in a much higher length. So with these things in mind, with this biology in mind, with this anatomy in mind, with these biomaterials in mind, we are able to treat the cases I'm going to show you immediately. The first case I'm going to show you is this 7-year-old man with important vertical defects in the posterior lower mandible, in the posterior lower zone. We have treated the right side according to what I have just said. We go for the CBCT, we measure everything, we take care of the different anatomical structures that are forbidden to touch, let's say. And we designed this prototype of what we are going to finally have in terms of allograft scaffold. We design with the CBCT, and finally we go to the surgery. And this is 2020, when I did the surgery. We take care of the different structures I have just told you. Again, you can see here in the right side the muscles of the mylioideo that we have detached, and immediately the flap is going to increase the length. It's very easy. It is not dangerous, it's not risky if you don't go with the blade. That is very important. And finally, we install the bone graft, we fix the graft, we cover the graft with a resorbable membrane, and on top of this resorbable membrane, we use this AlpioRF to obtain a better healing if it's possible, according to the paper I have just shown you, to have a better healing, at least in the soft tissue. This is very important. The management of the soft tissue for bone augmentation is clearly the key point. We close everything very gently without tension, and this is the healing after 10 days, let's say. This is the image immediately after the surgery, where we can appreciate some bone on top of the basal bone of the patient. This is the image where we cannot see almost nothing there. And this is 6 months later. We have to wait time for the remodeling of the graft and to leave the body to grow by itself, because I told you, the bone is something that can grow by itself. We have here the CBCT scan after 6 months. Look at the images now, where we can see some bone on top of the basal bone, and we proceed after these 6 months for the surgery. 6 months later, we install the implants in the new bone. You can see the bleeding of the bone. We go for the suturing after installing the implants, and not only the implants, but also the final abutments. And this is the image after the implant installation. You see the CBCT scan of the distal implant. And finally, almost 1 year later, we finish with the prosthesis. And clearly you can see the difference of the graft and also the basal bone. This is 6 months later. The comparison between the day of the end of the prosthesis and 6 months later, we can appreciate some difference in the trabecula of the graft. This is 1 year later. Look on top, where you can see some corticalization of this graft. This is the before, the immediately finished, and this is 1 year later. Look 2 years later on the right side. Immediately finished, and 2 years later. Look at the CBCT where you can see the corticalization all around the implant. And this is 3 years later. And if we go through the way where this remodeling has been obtained, look at the X-ray when we finish the treatment, the difference between the graft and the basal bone, and how this bone graft is remodeling through the years. It takes time to have the final bone. And if we go for a biopsy, probably 6 months later, we are going to have probably a lot of quantity of biomaterial. But if we go 3 years or 4 years later, maybe it's the opposite. We are going to have more bone, native bone, real bone from the patient than biomaterial. So an important message is biology, it doesn't take 6 months. It doesn't take 9 months. One thing is the possibility to install the implant and that those implants are able to be loaded. This is an important thing. But the other thing is that we can have more bone from the patient than the biomaterial. Another important message is that there are biomaterials that the resorption is very slow or maybe never disappear, those biomaterials. But this kind of biomaterials, the allograft, is clearly remodeled in bone, autologous bone. Another similar case I'm going to show you is this female, 68 years old. Important to say is also all the risk factors has to be controlled, nothing to say about that, periodontal disease, smoking, systemic disease, etc. And we have, again, a patient that needs to be treated in the posterior lower part of the mandible, and we proceed with the same technique. This bone graft that is designed previously, but the evolution is not only in biomaterials, but also in technology. And today we have this possibility that when I started with this technology, we didn't have it. So today we have this technology where we can measure everything, where the nerve is, the millimeters that we are going to increase in vertical, in horizontal, everything. And again, we're going to treat a patient like this, where we have this concave, this vertical defect, where the floor of the mouth is sometimes on top of the crest. And we proceed as we do it usually. We do an incision to lift the flaps. We proceed to look for the nerve, to be aware where the nerve is and to be very gently treating the nerve, to lifting the lingual flap according to these techniques that I have told you, detaching the myloioidal muscle, the corticalization, and finally we proceed with the same technique. We place the graft, we fix the graft, and of course we need to put some screws to finally avoid the moving of this allogenic graft. On top, we go again with this Alpuref membrane, and finally we use this collagen membrane, and we suture everything very gently without tension. What we are able to obtain, this is immediately again after the surgery. We need time again, and after 6 months of healing, we are able to see clearly this allograft that is more calcified. And this is, again, very important to leave the body to grow. And look at the difference between and after the treatment, 6 months later, more or less. And we proceed to the implant installation. We install the implants, and if it's necessary in this situation, we can again increase in this case, the horizontal width of this mandible to avoid this fenestration or dehiscency that we have in this mesial implant. And we proceed in the normal way, increasing doing the GBR, the normal GBR, and finally we suture. This is the image where clearly, again, we can see the difference between the allograft and the basal bone. Look at here. The clinical image before the prosthesis installation. This is the prosthesis installation. The X-ray immediately after the definitive prosthesis. 1 year later, where we can see again this remodeling that we are obtaining, and look on top where we can see some corticalization again, and the trabecular is clearly changing all around the graft. The CBCT scan, and at the same time we proceed to the left side with the same technique, and you can see clearly that the length of the graft in some zones probably is 8 millimeters, 9 millimeters of increase, 10 millimeters, but of course in the tips, in the corners of the graft probably is 1 millimeter, 2 millimeters. This is important because we have to understand if we take a mean of this vertical bone augmentation, probably at the end is going to be 3-4 millimeters. But we have to know and to understand that we have a range. And to obtain an 8 millimeters or 9 millimeters of vertical increase, is that something very important to consider when we read the papers. Not only the mean, but also the range, at least in the cases as I'm showing you. And again, look immediately after the graft installation, where we, in this case, clearly want to increase 7 millimeters of height. And this is 6 months later, where the calcification of the graft clearly is shown in these X-rays. Look in the top of the slide where this is immediately after the bone graft, and in the lower one, we can see the calcification of the graft. And with this, we proceed again to the implant installation, and again, we are able to see the vascularization on top of the graft. This is very important. We eliminate those screws, we proceed to the implant installation, and again, if the buccal bone plate is thin, we can go for the normal GBR in a simultaneous approach, and we proceed to the final prosthesis. And this is the final prosthesis. Clearly, we see here the difference, but look at the implant in the distal aspect. Probably is an implant about 8 millimeters of length, 3 millimeters in the basal bone, and 5 millimeters in the allograft scaffold. And another case, very similar situation, we proceed with the same technique. Look at the final result, the final prosthesis. Another situation in the front lower jaw. We can measure everything, the thick, the length of the graft, everything what we want to obtain, and we proceed for the surgery according to what we have pre-planned. And this is the block, this is the collagen membrane, the suture, and finally the healing of the case. With this in mind, we have collected our first, let's say, 11 cases with this technique. We have compared these 11 cases in a retrospective cohort study with 9 cases that we have done beforehand with this prefabricated similar technology, but not CAD/CAM custom milled. These are the 9 cases with the prefabricated block grafts, and these are the new cases, 11 cases, and we try to compare the difference between both of them. I have moved on to this CAD/CAM mill grafts because I had obtained a very nice result with these prefabricated block grafts. So I wanted to know if with this new technology we were able to obtain even better results. And the results here, in terms of vertical, I cannot use the laser, but you see in the first column, the vertical mean distance is about the total 3 millimeters. But important to say that the maximum for the group B, that is the CAD-CAM made, is almost 9 millimeters. This is very important to understand it, that we are able to increase in a vertical way at least 9 millimeters. The other group, that is the N is less in this vertical dimension, as you can see, is 6.5. In the horizontal aspect, again, you can see 10 millimeters, the maximum, and 7 millimeters in the other group. In a mean, considering the two groups, 3.5 millimeters. So probably this is in a similar, the results are very similar to what we have in the literature, because the literature clearly says us that in a mean we are able to increase 4 millimeters the bone in a vertical direction. But again, very important to understand that we are able to increase in a mean or in a range is totally different, because the grafts has sometimes in the middle 8, 7 millimeters or even 10 millimeters in vertical dimension. And this is very important to understand it from a biological and clinical point of view. In terms of resorption, that was another variable that we wanted to know. These new biomaterials, the quantity of resorption is less than in the other biomaterials, 70% and to 12.5% of resorption with this new technology. But also very important is the time. The time is something that is very important for our patients, not only during the surgery, but also for the post-operative complication that we are going to deal with. And in these cases, we are able to reduce at least almost in 1 hour our surgeries. And this is, in my opinion, a variable that is very important to consider and to understand. In terms of the follow-up of the implants that were installed in these grafts, I show you 53 implants. And all the implants, the insertion torque was also very high, in my opinion, was with a mean of 26 for all the implants, with the range also was variable, as you can see in the table. Of course, in terms of bone loss of the implants along this follow-up was very small. Very few millimeters were lost in this implant, as you can see, 0.4 millimeters in the mean. So the conclusions of this study are very clear, and the conclusions come up with that these two technologies are good enough to treat our patients, the prefabricated block grafts and these CAD-CAM block grafts. But in my opinion, these CAD-CAM block grafts are easier to use. The length of the surgery is much less, the resorption is less, and the comfortability for the patient is much less. So, and probably in these cases that I have prepared for this manuscript, the cases coming from the CAD-CAM allografts are worse in terms of these defects, these measurements of the defects. So important to say this also as a message. And in both grafts, the bone loss is very, very small, as you can see. So, dear colleagues, dear friends, let me finish with some conclusions. In my opinion, the biology and the anatomy is something that should be mandatory to understand 100% and to manage 100%. I cannot understand how a clinician can cut some tissues without knowing which tissues he is cutting. This is something that I don't understand. The second message is that the bone tissue is a tissue that grows by itself, like the epithelium, for example. In the same way, it has a turnover that is called the remodeling, that takes time. And as I have shown you from a biological point of view, our body changed the skeleton in 10 years, thanks to this biological joint work that these cells do together, the osteoblast, and the osteocytes. And of course, the bone tissue regeneration is something that is, I'm not going to say that is very easy to do, but of course you need a learning curve, but if one can do it, everyone should do it. The only difference is the understanding of what you are doing and also to be very well trained. Of course, the future is clear. In my opinion, this technology is going to be improved with these new tissue engineering scaffold materials that is going to individualize the defects for all our patients, and in an easier way, we are going to be able to treat them. Synthetic carriers, scaffolds, the using of mesenchymal stem cells, but probably not mesenchymal stem cells, but maybe the proteome of these mesenchymal stem cells, or why not this ALPRF in another, let's say, improvement in the near future. But because we have to understand that this ALPRF is just an improved coagulum. Is an improved coagulum. So I think this is very important to understand that if we always say that in the coagulum is the biological mediators, is the biological key points to obtain the regeneration, we need always, we talk about, we need the stabilization of the coagulum. But this ALPRF is a coagulum and probably improved. The problem is that maybe we are not able to use it today in the right way. We have to go on working and researching in this line, not only in the scaffold, but also in these biological mediators, such as the growth factors and differentiation factors and other molecules. So with this, and before leaving the stage, I would like to say thank you to all of you for your kind attention, but don't remember that all the ways are very difficult. Not the Camino de Santiago that is easy to do, but at the end of the story, the human being is able to reach whatever he wants to reach. So thank you very much for your kind attention.
Welcome, everybody. I'm especially thrilled to present the next speaker. He is Professor Dr. Nart. He obtained his specialization in periodontology and implant dentistry at the University of Tufts in Boston. He is our actual president in the Spanish Society of Periodontology, and he is chairman and director of the program Master in Periodontology at the University International of Catalonia in Barcelona. He's also my mentor, and he has been a great inspiration in my career, and I hope he will be the same for you too. I'm sure of that. So I just can say enjoy it.
Thank you very much. Thank you. Thank you for being here with us at this Sepa session. Thank you for dedicating your time to our lectures. I'll be speaking on how we have changed on immediate implant therapy from the last 10 years probably, and what are the things we're doing today. So basically, this is the topics I'm going to be following. And again, as I said, the way we have approached immediate implant placement is way different today from a few years ago. in fact, some of us, we were signing this consensus that I really do not agree on the many things that I had signed and approved by then today, or I practice differently. But it is fair to say that when we are agreeing or describing this type of consensus, we tend to be conservative as we feel this is going to be used by many general dentists. So we better be conservative. And at that time, what we said is that, yes, immediate implant placement comes along with grafting quite often, and it provides some benefits for patients, shortens treatment time, and probably cost efficiency as well. But it was mainly recommended for non-aesthetic areas, always with a very thick phenotype, in thick phenotype patients with thick buccal wall. Is it what we're doing these days? I don't think so. Very often, patients come with buccal dehiscences, natural buccal dehiscences, or after disease buccal dehiscences, and we still do immediate implant placement. So what I'm going to be doing mainly clinically is an overview of what we have been doing in the past and what we're doing these days with this concomitant regeneration on immediate implant placement. I'll show a couple of recent cases with the new series of implants from Straumann with a TLC, in which we are these days able to extract molars with non-treatable prognosis and then achieve primary stability right in the center of the septum and just let the socket to heal after proper debridement and no grafting, scanning 3 months later and providing this crown. I did not do any grafting at all. It's a thick phenotype with a thick buccal wall and nothing was needed. We know that the shrinkage horizontally that we will have in between two teeth is less than if we're doing extractions of all the maxilla. And so, maybe the crown will be slightly premolarized, but enough for the patient to function. So nothing more than the implant was done. For this class 3 mobility central incisor, something similar was done. It's a thick phenotype, as you can tell from the picture, and I exactly did the same. Extraction, debridement, immediate implant placement is a polish color implant, ideal for this highly susceptible to inflammation patients. And 3 months later, scanning and single restoration provided. Shall I had grafted? Shall I ask the patient to invest money on grafting, hard tissue or soft tissue? According to the results, I don't think so. This was so easy, so little invasive for the patient. Maybe just one single dose of amoxicillin prior to the surgery, and then one ibuprofen right after, and nothing more than that. A couple of appointments, the last one to the liver, end of the story. Is this applicable to every single immediate implant? No, I don't think so. Clinical scenarios are very different. Let's start with this one. It's also a rather old case in a patient, again, with a very thick phenotype. And we are aiming not only to treat her period disease, periodontitis, stage 4, grade B, as you can see here. And this is obviously the first steps of therapy before going to implant therapy. But we are also aiming to improve her smile. How are we doing this these days? We're doing it by means of digital dentistry or having the aids of digital dentistry. So we are scanning CBCTs, we're performing smile analysis, and we're getting the teeth we are aiming for, we're willing to have. According to those, we're going to merge no longer her teeth as reference, but the walks up, and then the bone she has, and let's see if we can coordinate the two of them, the implant position with the teeth. And if this is the case, we'll go for it. Of course, and again, steps 1, behavioral changes and supragingival debridement, instrumentation and subgingival debridement were performed. And then once this is achieved, we're going for the extractions of these only front teeth and immediate implant placement. You can notice from the CT scan and preparation that I've prepared this case again for a regular tissue level type of implant. Would I do this for every patient? No, I would not. She's a highly susceptible patient to periodontitis and then to peri-implantitis as well. And I'm protecting herself, of course, through the supportive therapy, but through the implant design, the macro design as well. These days, we're being helped for those cases, or we can, or we may, through guided surgery. And again, we've reduced inflammation. We've ensured that the patient is able to provide herself a good biofilm control, and then the rest of it is just mechanical. We plan and we work accordingly, okay? So 3 implants are placed, canine to canine, according to the new teeth to be delivered, and this is right after the surgery. Again, no grafting whatsoever, no hard tissue, no soft tissue, very thick phenotype. We are aiming, if you see, on the smile design to go higher. When we are aiming to go higher, we are really not, we don't have a concern on the thickness of the tissue so much. We are aiming with the temporary and with the implant positioning to go higher. So again, this is what we delivered right after, again, the surgery, and this is the situation we have when we are completing the final prosthesis 3 months later. There was no, again, need for grafting. There's always a need for the steps 1 and 2 of therapy prior to implant placement, no question. And there is clearly a need of understanding where are we going. And you know, implants are not leading, but the prosthesis is clearly leading here. And understanding very well if we are having a thin or a thick phenotype in front of us. So a smile is improved, as you saw, and you'll see, and perio treatment is done, rehabilitation through implant therapy is done as well, and this is where we came from, and this is where we ended up. No grafting, just immediate implant placement in a very predictable manner. Are we facing all cases like this? Not, we are not, because the clinical scenarios are rather different. And again, you know that many patients come to us in the need of extractions with already existing bone defects or buccal dehiscences or fenestrations. And then, yes, there is a need to graft. Sepa, with DGI and with the Osteology Foundation, promoted a consensus workshop, and of course, with prior review of the evidence. And this is in Madrid. This happened 2-3 years ago with very nice gathered information. And I'll be using 2 parts of this consensus to basically guide you through the way I approach these cases. The issue is not really whether we place immediate implants or we don't. The issue is how do we place immediate implants? And of course, if we buccally place them, we'll have an issue. We'll have a dehiscence, then deficiency probably. But no matter if it's delayed or immediate. So it's not on the technique, but it's of understanding the angulation of the implant. Of course, if we're dealing with thin tissue phenotypes, we are closer to having risks and issues regarding the contour of the prosthesis. But if we use connective tissues or we increase the thickness of the tissue, then we are far from having buccal deficiencies, okay? So proper 3D positioning and having thicker tissues as you've seen in the cases, all thick phenotypes, are really what we are aiming in order to have a stability in the long term, even with immediate implant placement. So we are not at higher risk. And we honestly, before doing this research on this, on the information on the topic, we thought that immediate implant placements were related to buccal deficiencies or dehiscences in the long term, but it is not. It's more on the position and the thickness of the tissue. So let's start with more challenging cases with buccal dehiscences. This is a case with a horizontal fracture on number 21, Europe, number 9, US, in which there's an abscess and non-restorable tooth. And you see it's going to be extracted. But what I'm looking here is what am I going to be doing? And the challenge to me really is preserving the scalloping of the soft tissues. This is what I'm thinking when I'm looking at this image. I'm not really caring these days on the presence or the absence of the buccal bone. I understand we should care, but it is not what's in my mind. What is in my mind is to look at the CT scan and see if I have enough bone in the palatal side to anchor the implant with primary stability. This is what it's in my mind. And at the same time, preserving the scalloping of the soft tissue. We know that buccally regenerating inside the alveolar envelope or contour is very predictable. We've seen it before. And everything we need to do here is regenerating inside the alveolar envelope. Periopixel has beautiful illustrations as this one, and this is exactly what I was meaning. I am only focused if I have enough bone to anchor the implant in its proper position on the palatal side, and then we have plenty of space to do some regeneration. And as you can tell here, we have plenty of space inside the alveolar contour to do this regeneration, no matter if the buccal bone is present or absent. Now, we cannot place the implant angulated buccally or the whole body close to the buccal wall, because then we're in the limit of what's to be regenerated. We need to be really inside the alveolar envelope, okay? So in this scenario, which is the scenario this particular patient has, we have plenty of room once the implant is placed where it has to be, plenty of room on the buccal side to do regeneration. For this particular case, I added a xenograft, collagen membrane, long-lasting, and then tissue from tuberosity, which is rather thick. And then, I split it, I thin it, and I undermined it, as you can tell there. Tissue from tuberosity has shown some advantages, and one of these seems to be the dimensional stability over time. We're collecting data to publish the 5-year results on the randomized trial we did on palatal tissue versus tuberosity tissue. And it seems that the tuberosity tissue can be more stable over time, even sometimes growing. It can be harvested in different ways. What is great is that the morbidity for the patient is very reduced, and the tissue, the amount of lamina propria is fantastic, and the amount of submucosa is very well reduced. In a paper, along with the Complutense team, we showed it. I think it's very cited. So if you're aiming to harvest high-quality tissue, tuberosity is a no-failure site, because the very little amount of submucosa. So what we did then is, again, implant is placed adequately where it has to be, simultaneous regeneration on the buccal side. The prosto has a space to work on the emergence profile. And this is what we had achieved, where we were coming from and what we had achieved. I'm really focused on the mid-buccal, of course, but the distal papilla is really a challenge. And keeping the distal papilla height is crucial. So moving on more challenging cases, This is for 2 contiguous teeth, numbers 11 and 12, 7 and 8. I decided, although, of course, other treatment options can be applied, to go as well for immediate implant placement. Why? Basically, I'm thinking always on preserving the scalloping of the tissue. This is the most challenging part. And this has to be done, can be done with immediate temporization. Of course, I could do preservation and then work with ovoid pontics, but it makes it quite difficult on the temporary period of time as well for the patient. So, yes, the periapical lesions are quite big, but the evidence says that if we are able to debride or remove them and clean them mechanically, it does not affect the implant success. So looking at the CT scan of the lateral incisor and central incisor, we have 2 types of different defects. One for the lateral incisor, which is a 4-wall defect with an important periapical lesion, and the buccal at the central incisor instead seems to have a full dehiscence on the buccal side. And then you wonder, how did I stabilize the implants, or how did I do it? Well, I understand the implants have barely one unique position, which is exiting in the cingulum. And with the macro designs we do have today, we might be able to do it. It is not a case that I would recommend our residents to go for immediate implant placement. This has to be clear, okay? This is when you get some training and confidence and you're understanding this, exactly this. The implants are placed where they have to. They have enough space between one to the other. It's a 3.3 and a 2.9. I'm ensuring the space between the 2 implants. It's 12. These are 12 in length, so with this we have enough primary stability. And this therapy works very well when achieving primary stability, ideal implant positioning, grafting simultaneously, 2 different scenarios, we'll just mention it now, and immediate temporization to preserve, again, the scalloping and the papilla in between implants, which is the most challenging part. And again, it's a 4-wall socket defect for the lateral incisor, then just a xenograft is going to be placed here, buccally to number 12, to the lateral incisor, but there's a missing buccal wall in the central incisor. So what I'm going to be doing there is a xenograft, collagen membrane, and then for both, a small piece of connective tissue, high quality from the tuberosity. But before that, and for everyone to understand where are we, we are not really in this left side scenario, but we are on the right side scenario, in which things are predictable. If I'm on the left side scenario, we have no space to the predictable limits to regenerate, but if we're in the your right side scenario, we have plenty of room to regenerate, and it is certainly predictable inside the bony envelope. I was showing exactly these 2 images when speaking at the EAO in Lisbon a few years ago, and right after me was Luca de Stavola speaking, and I said, to regenerate outside the bony envelope, you might need to be Luca de Stavola. And the first thing he said when he went into the podium is, no, Jose, you're very right. Even myself, we are only doing regeneration inside the bony envelope, being helped by the bony peaks, mesially and distally. And this is exactly what the picture basically says. Here we can add different biomaterials and different techniques. And to be honest, this is still discussion on what are we needing to do right there. And there's scarce evidence, and of course then we're building the evidence by randomized trials. In barring these scenarios, when the buccal bone is missing, are we always needing a connective tissue? Are we only needing the biomaterials and then the connective tissue, and we can avoid the membrane? This is yet to be understood better. So look at the clinical picture. Implants properly placed 3D, exiting where the prostonids, 4-wall, xenograft, and a connective tissue on the buccal side. For the central, you see the bone xenograft, the collagen membrane, and the connective tissue, both coming from a tuberosity and being split in two. The technique is rather simple, 15 C blades, and then Allen type of tunnelizer, being very gentle with the movements. No need to go past the mucogingival junction. There's no need for advancement of the flap. I'm just creating a space in order to have the connective tissue place. Single suture. Sometimes there's not even a need for suture if you're blocking with a temporary. And if you don't go past the mucogingival junction, you're just leaving the space for the graft. And it's time for the pros to work. I should have said to the pros that I've done this mainly to achieve the best scalloping out of what we can, what biology allows as well. But my dear brother, he closed the papilla in between implants more than probably I should have advised. And he modified it afterwards a little bit, but in any case, you see, we did the extractions, we debrided the lesions, we did the implants, and the simultaneous grafting, immediate temporary. Look at the chair side time, look at the morbidity, very reduced, and this is the scenario after temporaries 3 months later. Look at the thickness achieved, very predictably. Look at the amount of the connective tissue from tuberosity I used, reduced. Certainly a thick phenotype, and this is key on my decision. But would I have changed that if it's a thin phenotype? No, I would have not. I would have done the same with a thicker tissue from the tuberosity, if it's a thin phenotype, okay? Now it's then time for developing the emergence profile and then the prosto, working with the lab and achieving the most natural situation we can for the patient, of course. And you might want to be knowing what happened in the CT scan in the long term. I needed to do another implant in a posterior section for this patient, and she was kind enough to allow me to do the CT scan for the whole upper maxilla. And this is what I found more than a year later. So you see again, when we are inside the alveolar envelope, regeneration is predictable to happen. If we are asking ourselves to be outside the alveolar envelope, then things might get more complicated, and we like to work based on predictability, of course, and based on prompts, on what the patient perceives. We're moving our research to what the patient perceives. We're moving our practice, clinical practice, not based on what we like, but based on what the patient perceives. And this message has been said here by Anna and by Bea in the peri-implantitis lecture, and by Prof. Blanco again when doing guided bone regeneration as well. And this is something we keep mentioning. So are we having limitations for immediate implant placement, or immediate implant placement can be done everywhere and for every single case? No, of course we're having. Yes, we do have. Which are these limitations? The limitations we're having are not only buccal dehiscences, but most importantly, palatal bone loss. There's no way I will have the head of my implant in the apex of the tooth. There's no way I want to have such a long sulcus or such a scenario prone to inflammation. I won't do it. So there's no way I can place an immediate implant placement for this particular site. I will delay, and it's a case, fantastic case for ridge preservation, flapless approach, and mineralized allograft, no question. So this is clearly a limitation, and another case, even with a thick phenotype, in which, again, palatal dehiscence, and then not ideal for immediate implant placement. So certainly the palatal bone dictates if we are going to be able to place the implant and the height of it. So yes, there are limitations. And I'd like to share one last case with you, quite challenging, that we've done recently. And it's challenging because this beautiful woman shows a very high smile. because she's going to be picky on every detail. And of course, she's going to be asking to maintain the same scalloping on the tissues and to have the same shape of the tooth and beautiful ceramics for sure. And it is, of course, because you can tell that it has a fistula as well on the buccal side, and so quite important probably bone loss. And the bone loss is coming from the palatal mainly, and there's a big nasopalatine space there, artery there, with very little space for the implant, very little. So I'm thinking, what are the advantages of the immediate implant placement? Well, easy. We can do everything in one shot. Great for the patient, even for us, but it has to work. It's not just a matter of shooting, you know. It's a matter of understanding how predictable is going to be my approach. And for that, I need to, in this particular space, achieve primary stability, and then do regeneration simultaneously. Sometimes I might not be able to do immediate loading. Maybe this is a case, but I can use a Maryland temporary to hold the tissue mechanically. Again, palatally and mesially and distally the papillas. So what is the alternative? Extraction, cleaning, and ridge preservation. Certainly, we could do ridge preservation. And what is the approach after ridge preservation? Well, the implant positioning is not so easy, even with after ridge preservation, but we can do guided surgery, certainly. So this is an approach. And again, the way I planned this case is telling to the patient that most probably I won't be able to place the implant. Most probably I will not. And I will only do it if I achieve primary stability, and it's exactly what I want to have it. And of course, that we were going to need simultaneous regeneration, hard tissue and soft tissue. So what we did is I was able with these macro designs to achieve the primary stability I wanted to. And on the buccal side, there is bone, and we have undermined a connective tissue that you can tell there. And what about the fistula? Well, the fistula was taken care by mechanical debridement, as we do, and systemic antibiotics prior to the implant placement and after the implant placement for this particular case. It was too risky, and my insertion torque was not that high, so we went in that scenario for temporary with a Maryland type of provisional. Temporary restoration for those cases are just, you know, a need. It's really mandatory to hold in place the soft tissue, okay, the papillas and the height. And you see, this is where we can have 3 months later in a very predictable manner. I am certainly happy with the result, and so the patient is. It was done in a very easy way. You see, no invasion almost. But if you look carefully to a detail, and I do, you'll see on the buccal side like a 2-line of healing. And this happens sometimes. And I wanted to show this case because this is one of the complications we might have, and if we can call this a complication, which I think it's treated in a beautiful manner. But you see, when we place the connective tissue, if we are not de-epithelializing the circular epithelium enough, the connective tissue needs to face the connective tissue. If the connective tissue faces partially epithelium, it takes time for the epithelium to basically die. And then there are like 2 lines of incision, and you can tell on the above the implant restoration, the mucosal margin of implant number 8 or 11, you can tell that second line of connective tissue healing. You can see as well CT scan right after. I had no more space than where I could place the implant, and it's exactly what I aimed for. And we've been able to provide, I think, or maintain her beautiful smile and the contours of the soft tissue in a scallop manner, mesially and distally, Even look for the height of the distal papilla. Normally gets shorter after immediate implant placement. Look how it's very well preserved. We're extending the connective tissue a little bit into the base of the papilla, aiming to maintain this perfect scalloping. And again, probably somehow extra tissue of this line in the mid-facial. Ceramics, I think, is very beautiful. And I thank my brother for his dedication. So this is where we started, and this is the way we ended up only 3 months later, three and a half months later, with the restoration. In the same workshop promoted by Sepa Osteology and the DGI, we've drawn some conclusions, and this is from my group, along with Ronnie, the elected president of the ITI, that certainly superior outcomes are achieved when we increase the thickness of the tissue buccally in our restorations. This makes a lot of sense, but it is approved, or this is tested and assessed by patients and by professionals, both. So it does make a lot of sense. And then again, and as we were saying before, the risk factors for buccal issues called deficiencies or dehiscences or deficiencies are not really the immediate implant placement, are not really the buccal bone thickness as we thought so in the past, but are the positioning, the 3D positioning of the implants, how thick is the phenotype, and we can increase, modify phenotypes, and if we are using connective tissues to modify those phenotypes. These are the key factors, but not so much the buccal bone, as you can tell, thickness, not that much if the implants are immediate or not. In many of those cases that are a little bit into the limit, and we'll have a discussion later on, why I have decided to do immediate implant placement. Certainly, and again, this is not, for some of the cases, I would not advise our residents to do so. These are cases to be delayed. But for experienced hands, we're only doing this on a regular basis. The prompts has a lot of value to me. How little I'm going to be bothering the patient if I'm able to do it predictably in all terms has, I think, a lot of weight in my decision. With this, thanking again your attention and your interest on this Sepa session, and congratulating Straumann for the 70 years of guidance and excellence. I'd like to thank the team back in Barcelona, these cases that were restored by my dear brother Luis, and the team in Sepa, which allows us to do so many scientific activities that then are diffused everywhere in the world. So thank you so much for your kind attention.
I'm sorry about that. Sorry. I was thanking Professor Nart for those his beautiful presentation, lecture, and those amazing cases that definitely you need to be a skilled and to have a good training and expertise in order to perform them and get those amazing results. So last but not least, we are going to talk about another shift in the paradigm of how we treat things from the soft tissues point of view. And for that, we have our last lecturer, Professor Ignacio Sanz Martin. Ignacio was trained also in Tufts University in Boston. After his training in periodontology and implant dentistry in the US, he came back to Europe and did a scholarship, an ITI scholarship in the University of Zurich. And after that, he came to Madrid, and we were lucky to have him for more than 7 years at the University Complutense of Madrid. Unfortunately, we have to see him leave to Switzerland, where he holds a clinical practice, a very successful one. We are very happy for him, but we were very sad to see him leave Complutense University. But still, he comes. He's visiting professor at Complutense University in Madrid, also at University Internacional of Catalunya in Barcelona, and he has also started to cooperate with the University of Geneva. He's an amazing clinician, very skilled. He's a wonderful lecturer and a very good friend. So please, Ignacio, the stage is yours.
Good morning, dear friends. Can you hear me? Yes? It's a pleasure being here with all of you. I want to thank you for being here this morning, to thank the scientific committee and to Sepa for this wonderful opportunity. My goal today is sharing with you what I believe has changed over the last years in the way we deal with patients that are asking for aesthetically pleasing results in the anterior aspect of the maxilla, and mainly dealing with what has changed in the way we manipulate soft tissues and in the way we use soft tissue grafting to improve the outcome. So let me just start by thanking, as Anna was saying, I've had the chance to be in many institutions, and I'm very thankful for everything that I have learned from many, many friends and many colleagues. A lot of them are here. So my message today is a lot of what I've gathered over the years and the research that I've done, and it's what I'd like to share with you today. So I'm currently in Lausanne, in Switzerland. This is where I practice, and this is where I spend most of my time. But as I was saying, my goal today was sharing with you what has changed in the way we treat patients, particularly in the way we deal with soft tissues, because if we look back 10, 15 years ago, we were all doing a lot of bone grafting procedures, but we didn't understand really why we were doing these procedures. So if I show you a situation, for example, like the one that I'll be showing you just in a minute, just to quickly tell you the way I'll structure the presentation is I'll be going a little bit over the background. I'll be giving you some of the evidence that justifies some of the procedures that you'll be showing today. And at the end, we will try to gather some clinical concepts and some applicability of how can we translate these findings into the decisions that we take every day in the clinical practice. So I was saying before, let me just quickly start by giving you some background and showing you a clinical case where you see there is a concavity. And this concavity obviously is going to have an impact for the patient, because these concavities create some shadows. The tissue is thin and the transmucosal components show, and obviously this, when we restore these patients, has negative impact. So I think what has changed in the way we deal with patients is the way we move from a situation like this to a situation like this. If I would have asked you 10, 15 years ago, you probably would have all said that you would have, in order to move from the previous slide to this slide, you would have used bone grafting procedures. And the way we think today is soft tissue has a more prominent role. And I hope you're all thinking about soft tissue grafting when you want to get to a case like this as opposed to bone grafting. Let me just quickly explain you, this is an old case, it almost has 12, 14 years ago, how I dealt with this case, in 2012, just after I was back from my ITI scholarship in Zurich, because I dealt somehow differently to the way I was taught and to some of the concepts that we learn in terms of bone augmentation procedures and how they help us in the daily practice. So this is a patient that had lost 21 previously and had a significant defect. And you can see that there is, as we were saying, a pretty significant concavity on the area of 21. And the way I planned this is I planned for a 3.5 millimeter implant, and you see that immediately on the buccal aspect there is at least 2.5 millimeters of bone, so I felt comfortably placing the implant guided. And then the tricky question here is, how are we going to solve this defect? Are we going to do a bone grafting procedure, or are we going to do a soft tissue grafting procedure to resolve this concavity? So the way I dealt it is, as Jose was saying previously, in a very non-invasive manner, trying to think about the patient. This is a flapless approach. I'm doing a slight crown lengthening on the adjacent tooth, and I'm using a connective tissue graft just to solve the concavity. And this connective tissue graft is fixed on the transmucosal aspect, which is the area that matters the most, the area where we need to resolve this ridge defect. And this is the area where the graft is placed. And we'll talk later, but the nature of the connective tissue graft that we use is certainly of importance. You will see a lot of white and little orange and little yellow. This is a lot of lamina propria, very little submucosa, and very little fatty tissue. So just one single suture, and this is the way the patient comes back. So we move from here to here, one single procedure, understanding where we needed to recuperate the volume and translating this into a positive outcome. Remember this concavity that we have, now it's almost a convexity. and this is the X-ray, and just a single crown on the implant and adhesive restoration on the lateral, and having a positive outcome for the patient. And these are the lateral images that I showed you before. So in a way, this case shows how we change the way we manage these cases. So let me just try to give you a little bit more of information. This is the volume change from the before and after. Significant change just with one single procedure, a fairly minimally invasive procedure. And I think what is very important, and we'll try to discuss later, is where does the soft tissue play a role? Because every bone grafting procedure is going to be helping us more to recuperate the volume in this magenta area, but the area where you see the cyan blue, more coronally and transmucosal region, is the region where the soft tissue is very, very important, and where we're going to use our connective tissue grafts to recuperate the volume that has been lost after tooth extraction. So this particular case was a case that we published in Perioclínica, which is the journal of the Spanish Society of Periodontology. And this was a publication that I did with my friends from colleague, Ronnie Young and Danny Toma. And I just want to take a quick minute to just explain you about the journal of Perioclínica, which I happen to direct, and is the journal of the Spanish Society of Periodontology. And you may check on the website, which is perioclinica.com. We just came up with an interesting issue, which is explaining about implant surface decontamination. This is the issue number 27, but there are many other issues that touch, I believe, in a very interesting way for clinicians, in a very didactic manner, what are some of the current problems that we're facing in daily practice. So here in this particular implant detoxification surface, we discuss about electrolytic approaches, we discuss about ultrasonics, we discuss about air abrasive lasers, pretty much everything you can find in the market to try to help you take better decisions in the daily practice. But as I was saying, this is not the only issue that we've had. We've discussed the previous issue was management of recessions in the fifth sextant, biologically oriented tooth preparations, microsurgical techniques. We also made recently an issue about the science and practice of tooth autotransplantation, management of excessive gingival display. So this is, I think, very interesting and very enriching for you. These are issues that are filled with worldwide experts. So if you get a minute, I would encourage you to check that. I think you will find it of use. So let's quickly go back to the topic that we were discussing, which was this case. And I was telling you that I was giving you a little bit of a background of what has changed. But let me just make a pause and let's dig into a little bit of the evidence, because I think today we have more and more evidence that points into this direction. It's just not a beautiful case, but you will see that the evidence seems to indicate that soft tissue has a more prominent role when we try to rebuild the loss that occurs after tooth extraction. So if we look at a little bit more into the publications, I want to start with this particular publication, because if we go back very quickly to the case that I was showing you, and I ask you how much of a volume do you think you would recuperate if you would just perform a bone augmentation procedure in this particular case? From the concavity that we have, if you perform a bone augmentation procedure, what percentage do you recover just with the bone augmentation procedure? And I have to tell you that this is one of the questions that we ask ourselves as part of my PhD thesis that I performed in Universidad Complutense de Madrid under the direction of Professor Mariano Sanz. And basically what we had was 3 scenarios. This is just before tooth extraction on the yellow, after tooth extraction, and after bone augmentation procedure. And here the question that we ask ourselves, we made a number of measurements after we digitalized these models and we perform STL superimposition. And the question that we ask is, how much were we able to recuperate of the volume that we lost just with bone augmentation procedures? And I have to tell you, the numbers are a bit disappointing, because all that we could manage to gather is about 1/3. We could recuperate about 1/3 of the volume that was lost after tooth extraction, just with the bone augmentation procedure. So if you want to recuperate the whole volume, certainly what you do with the soft tissues is of critical importance, right? Just the bone augmentations will not help, clearly. So I think what we have to discuss is what happens from here to the left to this image that you see on the right, this is what happens when we extract a tooth. And I have to tell you that our understanding of what happens after we extract a tooth has changed over the last 15 years. And has changed because the tools that we have and the means that we have to study what happens after we extract the tooth has changed. Now we have very powerful tools that allows us to understand three-dimensionally what happens after we extract a tooth. So what I could say is that the understanding of what happens in terms of alveolar socket healing has really seen an evolution. If we look at, for example, the first studies from /Rob that were only looking at two-dimensional periapical X-rays, how much data can we gather from this? You know, very minimal. But obviously, the classic Araujo studies were certainly very helpful 10, 15 years ago, but we're looking at 40 microns of a slide. And the amount of data that we can gather here is certainly very limited. But obviously, the team from Complutense has also, you know, we have studied these data and has also given us insight on the way the sockets heal, but it hasn't been until we have started using three-dimensional technology that we've really been able to better understand what happens after tooth extraction. And first, it was in Zurich and in Munich that they started to use this technology, superimposing models that allows us to better understand. And we also, as part of my thesis, we developed a model that helped, but this study particularly by the group of Bern in Bibi and Chapuis, they superimpose DICOM models and STL models, and this is when we really started to understand the interaction between the soft and the hard tissue after extraction. And as I was saying, we also contributed with a model that superimposed CBCT and STL data, and this has also been done by other groups like the group from Jan Kosin that really has also dig into this to gather more interesting and more insightful data. So once again, if I show you this picture and I show you really what happens after tooth extraction, it's really simple what happens. We get a collapse, volumetric collapse, a contour loss. We have a bone loss, clearly, but what we've understood is that there is an interaction between the bone and the soft tissue. And the space that is left by the bone is occupied by a physiological increase in the soft tissue. So the soft tissues are getting thicker after we do the extraction. And this is, as I was saying before, what very well depicts this study from the Bern group and Bibi and Chapuis, which basically tells us that after tooth extraction, particularly in patients that have thin phenotype, the space that is taken by the bone resorption is taken by the soft tissue. So there is an increase in the thickness of the soft tissue naturally of 7 times after there is an extraction. And that's why this group gets very, very good results in delayed immediate without any soft tissue grafting, because they're using just nature to thicken the tissue naturally, particularly in cases of thin phenotypes. So this clearly changed the way we approach these cases. And this is also what we discuss and what we evaluate in my PhD, where, as I was explaining you before, we superimpose 2 types of images. This is STL and DICOM data, and we started to create a model that allows us to better understand. Excuse me, just I quickly go back so you can see the rendering of this image here. Basically, these type of models where you can see the soft tissue and the hard tissue superimpose, and you can understand and you can start to measure volumetric and linearly these issues to try to better understand what happens. And you can see clearly differences, as Jose was explaining us, between the immediate and the delayed. Clearly, the immediates here on the left, you see very little soft tissue in the supracrystal region. You see defects on the areas that were not grafted, and on the areas of the delayed where the soft tissue got increased physiologically, you see much more soft tissue here on the transmucosal regions, which is certainly of interest. We studied almost 40 implants, and we could clearly see a difference between the immediate, where you see a collapse, and a delayed, where you see almost a gain in the contours, because we just move the tissue that got physiologically thicker after the extraction to the facially, just by a simple flap procedure. And what was actually very interesting to see is when we made correlations of the values that we made, one of the dogmas that we've received is that the bone volume is going to correlate with the soft tissue volume. So if we have a lot of bone on the buccal of the implant, we will have a lot of tissue on the buccal of the implant, and the tissue will be high, right? So these correlations were certainly true for immediate implants, but when we looked at delayed implants, these correlations did not hold true. And the hypothesis that we had is that the fact that the tissue was thicker could mask some of the hard tissue problems that we had in these type of situations. So I think this was certainly some relevant data that we could gather, obviously just from experimental studies. But it points, I think, in some direction that soft tissue obviously could potentially help in masking some of these deficiencies. So if we look at back in the literature, the evolution of the knowledge moves from mainly two-dimensional images, as I was saying, to studies that have started to point out what are some of the benefits of connective tissue grafting. And connective tissue grafting to compensate the physiologic contour loss and volume loss that happens after tooth extraction. So we could use soft tissue grafting to really compensate for these changes. And I think if I pointed to you some very interesting studies that in this interaction between soft and hard tissue, what we can start to understand is that some studies tell us that there is no correlation between the buccal bone thickness and what happens in the soft tissue height in immediate implants. And also some studies that tells us that even we can have acceptable aesthetics even if we have a thin buccal plate. And this is the study from Mario Beltri. And I'm just going to show you very quickly a slide of one of the figures of this study, because I think this is fascinating. Some of the dogmas that we've received is that if we have a lot of bone on the buccal aspect, the tissue will be good. And if we don't have, if there are bony dehiscencies, we will have also soft tissue fenestration, soft tissue dehiscencies, right? And what this study shows is that in many of the cases, you see that there are bony dehiscencies, so there is no bone on the buccal aspect, but yet in none of the cases you see that there is a soft tissue dehiscence, that there is a recession around the implant. You may see that the soft tissue looks more translucent, it looks more gray, but you see that the soft tissue hasn't migrated apically. And I have to tell you that the reason why soft tissue migrates apically around implants has not been very well understood. And when we look at the literature, if we try to find the reasons, you have what's called a multifactorial etiology, which means what? Which means there are many factors that seem to be influencing this. And basically, you may think that is the implant that is more buccally placed, or maybe there is a bone deficiency, or maybe it's just the crown or the abutment that is over contour, or maybe there is the soft tissue phenotype. So there is a lot of questions, and what we try to do is try to better understand a little bit of the reverse way, as opposed to trying to understand why these deficiencies occur. We try to get these cases and try to understand where is the problem coming from. And we gather a number of cases at the beginning in a very empiric fashion, and we try to understand where is the common problem in these cases. And one of the first things that we try to understand is the position of the implant, and the first thing that we came into consideration is that after these 30 implants, only 4 were considered being placed in a prosthetically adequate position. And we went further into this, and basically we published a paper that looked into, in a case control fashion, over 100 patients, and looked at 52 controls and 52 cases. And this, basically what we tried to do is understand what were the differences between patients that had soft tissue dehiscence and patients that did not have soft tissue dehiscence, right? And the particular thing about this investigation is that we looked at also 3-dimensional data. And what we gather is that obviously some of the parameters were very different. For example, the keratinized mucosa was higher in the cases in the controls than in the cases. And if we look at, for example, other values, such as, for example, the bone height, there were the distance from the bone shoulder to the first bone to implant contact in the cases was almost about 4.8 millimeters, in the controls was just about 2 millimeters, right? But when we perform a more sophisticated statistical analysis and we try to see in a logistic regression analysis, try to understand what were the odds ratios and taking everything into consideration, we found that the most significant factor was the position of the implant. And having an implant that was just placed 0.5 millimeter outside the alveolar envelope increased the chances of belonging to the cases up to 35 times, which is really, really striking. So just making a little mistake with the implant and having the implant position 0.5 millimeter outside the alveolar envelope is increasing the chances of having, in this particular case, the implants belonging to the cases of 35 times. This is a case control, so we're only looking at the case, at the patients in a snapshot in time, and we cannot talk about development, right? We're only seeing the patients one, and we're trying to analyze why are these patients belonging to this one group or the other. Another thing that we found was very interesting is that implants that were considered soft tissue level implants had more chances, almost 12 times more chances of belonging to what we call the cases. But finally, also what I wanted to tell you is that the first bone to implant contact, which historically we've been told that plays a very, very significant role, in this particular study did not reach significance. The odds ratio was 1.23, which means that this did not have an impact on whether the implants belong to the cases or the controls. So just to tell you some of the images quickly, you can see, for example, here an implant that has some bone on the most coronal aspect, but not any bone on the more apical aspect, and this was a case. But if I show you pretty much something that is identical, you see, it's the same type of image in a different implant, and you see actually this was a control, you see. So what I'm trying to tell you is that if you only look at the bone, you will not guess if the image that you see on the right is a case or a control. But when you start looking at the position of the implant, look at this position of the implant, how the implant is emerging completely outside of the alveolar envelope. If you look at the position of the implant and not at the position of the bone, then you will have very easy time guessing if the CBCT images tell you if this is a case or a control. Look at this other situation, for example, just quickly to explain you in this type of images that we built, in this type of models that we built, what happens when an implant is positioned bodily outside the alveolar envelope. Basically what you see is that the prosthetic components and the abutments are going to pierce through the soft tissue in this transmucosal region, and obviously the soft tissue is going to migrate apically. So the implant position is the single most important factor related to the development of these buccal soft tissue dehiscence around implants. If you see that if the implant is angled buccally, we're going to have exactly the same problem. So now if I show you this CBCT image, and you can see that obviously the implant angle is emerging through the buccal aspect, you can see that this is a problem. The implant should have been placed in a prosthetically ideal position, and because of the implant was not placed in this position, then obviously the patient has a buccal soft tissue dehiscence. And by understanding this, we could start to really see how we can treat these cases, because if we don't understand the problem, if we just perform a soft tissue graft here without manipulating the prosthodontic components and also changing the crown and also changing the abutment, we will never succeed long term. Let me just show you this other image, because this is very interesting. What happens when there is a bony dehiscence, but the implant is placed inside the alveolar envelope? Well, this is a question that we analyzed in this study. I will show you, in this particular patient with a thick phenotype, there was no soft tissue dehiscence, right? And this is not just an accident. We saw more and more cases like this. Does this mean that you shouldn't be performing guided bone regeneration procedures? Not at all. This is not, we are trying to understand where is the origin of the problem. This is not about whether you would leave a rough surface exposed that is more prone to plaque accumulation and more prone to periimplantitis. We're not discussing this. The issue here is that in this particular case, there is no bone on the buccal aspect, and yet because the implant is placed inside of the alveolar envelope, there is no soft tissue dehiscence. So what we try to understand in this Sepa osteology DGI consensus was we were trying to look now at prospective data. The data that I presented you was cross-sectional data, which means it's a snapshot in time of the population. Now we're looking at longitudinal data, studies that have evaluated factors, and they have seen over time how these risk factors develop. And basically, we were able to come up with this publication, which is a systematic review and a meta-analysis, and we looked at over 20 investigations, and basically that were following a number of factors. Let me see. They were following a number of factors, and we were trying to see if any of these factors had an impact on the development of soft tissue dehiscence around implants. And the conclusion that we gathered is that there were mainly 3 factors that had a clear role. This was the tissue phenotype, the buccally placed implants, and the implants that had a connective tissue. This was a protective role. If the tissue was thicker artificially with a connective tissue graft, the implants were less likely of developing a dehiscence. But what was also very interesting is that I have to say that there was a lesser degree of evidence, but the evidence seemed to point out that thin buccal plates and immediate implants did not have an impact, a negative impact in developing soft tissue dehiscence around implants. And this is something of a paradigm shift, because this is what we've been drilled for a very long time, you know, that this was the case. And that's why we perform bone augmentations right and left for many, many years, when maybe we should be performing soft tissue augmentation procedures if the implant is well embedded in bed and well surrounded in bone, sorry. So I was saying phenotype, connective tissue grafting, and most importantly, the implant position were the main factors, but buccal bone thickness and the timing of immediate implant placement, namely immediate implants, did not seem to have an impact. Mind you, there are just 2 studies on the left and 2 studies on the right, so limited evidence, but seems to point out in this direction. So now, for the last part of my presentation, let's discuss a little bit of the applicability of this, because we've been discussing a lot about the soft tissue, but what do we do, you know, with this information? How do we apply it on a daily basis, right? So let me just quickly start showing you one of the cases that I explained you before, which is a patient with a soft tissue dehiscence. How do we do in these cases? Do we perform a bone graft? Do we perform a soft tissue graft? Do we extract the implant, you know? So this is a patient, she's a dentist, and she has a high lip line, and you see she's very unhappy with the way this looks. And when we look at the lateral images, you can see that obviously the implant seems to be placed further to the vestibular aspect. In this type of cases, removing the crown is of paramount importance to understand where is the origin of the problem. And as I was saying before, in a lot of these cases, you can start to see that the position of the implant, the angulation of the implant is a problem. If you draw a line on the buccal aspect, if the implant is touching that line or is outside of that line, you have to think about removing the implant. If it's close to this line, you can potentially treat the implant and treat this dehiscence. You see there is no health problems. There's maybe a mucositis, but no preimplantitis in these cases. And you can start to see that the position of the implant is here the problem. So what do we need to do? We need to address the origin of this problem. And how do you address it? We need to address it by changing the position of the implant. And how do we change the position of the implant? With the prosthetic components. We're going to try to leave space for the soft tissue, and we're going to use angulated abutments to try to mask a change of the implant position that obviously we cannot change. So this is the abutment that I removed, and the first mistake was the abutment is, as you can see, it has a little bit of a belly. So it's pushing the soft tissues more apically. So we need something that is straight and that is not pushing the soft tissues at all. So I'm using a different abutment. This is gold fuse abutment that is leaving more space for the soft tissue. You can see that this image is very crucial because this is where the soft tissue was, and this is the space that I'm leaving for the soft tissue. And you will see very clearly the moment you leave space for the soft tissue is going to respond very favorably. This is a marginless abutment, so I'm not going more facially to leave more space for the soft tissue. I'm going very straight and very narrow. And that's why I'm using a metal abutment to have a little bit more of resistance. Very, very thin, about 0.3, 0.4 millimeters of thickness. And the moment we do this new abutment, you see provisional, and just 1 week after, see what the soft tissue does. The moment you leave space for the soft tissue, this is non-surgical, the soft tissue reacts, you gain keratinized tissue, and the soft tissue migrates coronally by not performing any procedure. Just understanding the problem here was that the prosthetic components were piercing the soft tissue. And obviously, this is now ready for surgery. You have to use a connective tissue graft, so I make a coronally advancement procedure with a connective tissue graft, sorry. This is the suturing, and this is the result 1 week after. This is 6 months after, and this is the new abutment, the provisional, the 1 week after, and this is 4 years after the procedure with better thickening of the tissue and better coverage of these dehiscents. But as Jose was saying, I think one of the things that we've understood over time is that the type of connective tissue graft that we use makes a difference. And we studied together with the UIC University at Mannheim in Complutense what were the differences between the lateral palate and the tuberosity. And you can see that there are clear differences, but here the message is that when we're grafting, particularly around implants, we need to be using this middle part, this white part that you see here and here. This is the lamina propria. This is rich, dense connective tissue that will not resorb, or that will have minimal resorption as you compare it, for example, to submucosa, which is very fatty and very glandular tissue that has more remodeling over time, better vascularization, but also more remodeling. And this is the publication that we performed, trying to understand the differences between these two. But at the end, I think what is important is that also through the clinical study, what we understood is that the lamina propria, what you graft, makes a difference in these type of situations. And just to finish, I will tell you that there has been an evolution of what we can do with soft tissue grafting around implants. If you look at 10, 15 years ago, we were only talking about keratinized mucosa augmentation around implants. But as time evolved, we started to using it, as Jose has explained, as around immediate implants to compensate for the physiologic changes that occur after tooth extraction. But then, as I've shown you before, we started to use it also in soft tissue dehiscences around implants once we understood what were the factors that were related to them. Then we also started to use, as I showed you in some of the first cases, to recuperate the volume. But today, we're also using it to gain soft tissue height. And this is what the evidence, sorry, I just go back very quickly, what some of the publications are showing us, that we can also use soft tissue grafting to gain soft tissue height around implants. So let me just quickly show you a couple of cases illustrating this. This is a patient that had a tooth extraction, and a young patient, and we've clearly, after the tooth extraction, lost the interproximal soft tissue height on the distal, and this is for the patient obviously not very ideal. So you can see that this deficiency can potentially have some aesthetic implications for the patient. So first of all, I want to understand how much of importance this is, and when you make a three-dimensional mock-up, you can clearly see that this, because of the differences between the contralateral sides, is probably going to represent a problem. So what I'm doing in this particular situation is I'm performing a guided surgery approach. I'm going to place a 3.3 millimeter implant, and then after this, I'm going to deal with the aesthetic, with the problem of the interproximal soft tissue. And here, basically, what I'm doing is I'm putting the implant in. This is a 3.3 millimeter. This is a little bit accelerated. I don't place the implant so fast. But what you can see is that I'm using a connective tissue graft to mainly gain more thickness on the buccal aspect. And then I'm also using a connective tissue graft to try to increase the region of the interproximal. I'm using a very slim abutment to leave space for the soft tissue. I don't want a very large abutment that is going to leave no space for this connective tissue graft. Primary wound closure. And then this is the way it looks at the 1 week follow-up. This is 3 weeks follow-up. And you can see here the implant placement. And this is the healing, where I've been able to recuperate the interproximal soft tissue by means of the soft tissue graft. We've, changing a little bit the situation from something where there was a papilla missing to recovering this precious soft tissue. Where it matters. If this patient would have had a low lip line, probably would be talking about something completely different. This was the initial, this was after the extraction, and this was 2 years after recovering the soft tissue height, once again by means of this soft tissue grafting. So these are the changes that you see. And what you can see is when we measure this, we see that there's a little bit more of distance than what we would anticipate. Another case, which is also, aesthetically is a concern for the patient. You see that there is no interproximal tissue on the lateral aspect. You can see there is on top of it the dehiscence. And the implant was placed, and after the implant was placed with the bone augmentation procedure, I'm going to perform the second stage connection, and here I'm performing a remote incision on the apical aspect, and I'm using 2 connective tissue grafts to try to recover the height that was lost. And you can see I'm also using a connective tissue graft on the facial aspect, and this is the suturing, and you can see this is the before, and this is the after. This is 1.5 years follow-up. Recovering the soft tissue that was lost, gaining soft tissue height through this augmentation procedure. In a patient, you see once again the X-rays. You can see very straight transmucosal profiles, leaving space for the soft tissue. And if you measure, you would see higher numbers than what we've classically been explained. This is about 7 millimeters from the contact point to the bone crest. In a patient, you see this is the smile of the patient before and after, and these are the clinical results. So in a patient that obviously it matters, not that we're going to do this for every case, but for these type of situations, this is of a service for the patient to have a more harmonious restoration. And this is the last case that I will show you today. Again, another challenging situation. You see not very harmonious soft tissue contours in a patient that also displays this. When I remove the prosthesis, I very quickly find that there is a fracture on the lateral in the middle. I'm not sure if you can see it. I don't have a laser to point it, but in the lateral you see a fracture line. So unfortunately this tooth is lost. So now, we already are beginning with a situation where we have the interproximal soft tissue higher. We're going to lose this lateral here. Potentially the tooth is going to migrate, the soft tissue is going to migrate more apically. And in this particular case, I'm performing an implant on the central, so then I can extract the lateral and I can try to do a soft tissue graft to gain some of the height that we have missing on the lateral. So this is after the implant placement, and then I just do a decoronation procedure, and this decoronation procedure is going to help me have a healed crest over the lateral, and then I will put a provisional restoration over the implant. This is the situation before the soft tissue grafting, so you can see again that for a patient that displays it, this will potentially create a higher contact, and this is not going to be pleasing for the patient. And after this decoronation, I can move into the surgery. Now I've performed the extraction of the root, and now I'm using again a connective tissue graft that is dense, that has high lamina propria component. This is a tuberosity graft. I'm fixing it over the bed with 7-0 resorbable sutures. And then I'm also going to be using a connective tissue graft on the more facial aspect of the implant, trying to recover some of the soft tissue height that was lost. So the implant is well surrounded by bone, but it's the soft tissues that are going to here be able to change the situation. And this is when the soft tissue grafts are fixed, the advancement of the graft. And this is after suturing, and where I'm putting back the provisional restoration after I perform a small crown lengthening on the adjacent central incisor. And this was the initial situation where we extracted the lateral, and we anticipated that we were going to have even more interproximal soft tissue loss because of the extraction. And this is the final result where we've been able to have a more harmonious results in terms of soft tissue height in a patient that displays it. And once again, if you look at the periapical X-rays, you can see that this is about 8 millimeter distance. So we can really have an important an increase of tissue height in these type of situations in order to achieve a positive outcome for the patient. So we've discussed a little bit about the background. I explained you how soft tissue grafting procedures can help in terms of recovering the soft tissue volume that has been lost after extraction. I try to give you a little bit of the evidence that points out into the use of these soft tissue grafts, and I've explained you that now we can not only use it for volume, but also for dehiscence and for soft tissue height. And finally, I showed you some cases, that explain a little bit of this concept and how you can use it in the daily practice. And with that, I'd like to say muchas gracias a todos. Ha sido un placer.
Please don't go down.
Mm-hmm.
Micro. On. We're on? No, you cannot hear me. Hello? Yeah. So thank you very much, Ignacio, for your wonderful lecture and those beautiful cases. A lot of food for thought, right? A lot of information. And now, please, I'm going to ask Professor José Nart and Juan Blanco to join the stage. And if you have any question, our lecturers will be more than delighted to help you. So any questions from the audience? Yeah?
I can have some questions. To Professor Juan Blanco.
Juan.
Maybe I'm here on the other side. Yes. To Professor Juan Blanco, a question is, you show them great cases, with vertical augmentation. And when you listen, for example, to Carlo Tinti, where is the limit to these vertical augmentations? And with allograft, you are just putting new boundaries into this vertical augmentation. He always says that non c'è limite, no, there is no limit. And I would like to know where is the limit for you? Where do you see the limit? And as well, the second question would be about because it's something that maybe you don't mention, but I think it's also important, the abutment height. And you have a publication in 2018 that shows that how important is that situations where we have a graft to have also these considerations, prosthetic considerations, and have the abutment height that goes up to 2.5, if I remember correctly.
Yeah, thank you. Thank you for the two questions. The first one is, of course, that there are limitations, and the limitations are genetically described. There is at least one paper that was published in 2023 by the group of Leuven, talking about the phenotype. So this means that even you go out of the envelope, with the coming years, you are going to obtain resorption of that bone that you put out of the envelope. So probably the clear thing here is the peaks of the bone, mesial and distal, and of course, on top of that, probably today is not possible to grow up. However, and if you go up of that limits, for sure that you are going to have resorption. So when you design your block, it's very important, or when you design regeneration, it's very important to understand the limits. And those limits is not the height by itself, is the mother nature, is the phenotype of the patient. And the second question was about the height of the abutments. Yeah. Well, you know that the supracrestal tissue in implant dentistry or in implants is about 3-4 millimeters. So if you go, and there are many papers talking about when the thickness of the mucosa is less than 2 millimeters. You need those millimeters to at least of mucosa to preserve the bone crest. And the best way to preserve that millimeters is to have something that can preserve them. And this is today the titanium or maybe the zirconium. So you need a height of at least 2.5 or 3 millimeters, because in those millimeters you don't count the sulcus, because the sulcus is what you can probe. So from the marginal to the marginal of the mucosa to the crest, anyway you are going to have 3-4 millimeters. And you need some millimeters of titanium to keep that soft tissue, that connective tissue, and the barrier epithelium attached to the abutment. Okay?
Thank you, Professor Blanco. Who else wants to pose a question to our speakers? No questions? I do have a few questions. Oh,
I stay stand.
Okay.
Regarding the allogenic bone graft, could you please explain more about the workflow, because it is the CAD/CAM and I'm not sure that how we do that. And the other question is that you place collagen membrane and PRF. Is it possible to use just only the PRF?
Okay, thank you for the two questions. The first one about the design of these blocks. Clearly, the key issue is the CBCT scan, because the CBCT scan needs to describe exactly the anatomy of the defect. So probably it's better to do it in the lower jaw than in the upper jaw. Why? Because in the lower jaw, with the cortical is very well limited and very well described in the CBCT, with no gaps, with no defects. However, when you have a defect in the maxilla, sometimes it's very difficult to the technician that is reading with the software, the CBCT, to describe exactly the profile. So very important, the first point is the CBCT, the quality of the CBCT. Then you need a software, like when you are doing a digitally surgical planning. It's exactly the same. You have to describe through this software exactly the design in terms of vertical, horizontal, and the three-dimensional, the block. And once you have designed this block, it's milled through a bone bank. They prepare it through a bone bank. And then they mill a femur, for example, the head of a femur, they mill it. It's a subtraction technique instead of a 3D printed. It's not 3D printed. It's CAD/CAM designed and made in terms of that finally you have to mill it. Do you understand the way how to prepare the block? Okay. And the second question, I don't remember the second one.
When we do the CAD/CAM, normally they use the water. So I think that maybe the bone contaminated with the water that they use to cut the bone.
Yeah. Finally, you have to sterilize everything. And they have, this company has a special way to sterilize everything. Of course, that everything has to be clean and sterile. Otherwise, you cannot use it in humans.
So it is not commercial.
It's not?
Commercially.
Comercial, si se vende, claro.
Yes, of course.
Si está comercializado.
Yes, it is. By several companies, not only one.
And the second question
The second question, the collagen membrane and LPRF on top.
Yes.
If we can avoid the collagen membrane. This collagen membrane is a long-standing collagen membrane. This means around 4 months. But if we don't have any data without collagen membrane, so I cannot tell you if probably it can works in the same way. I don't know, because I never did it. However, thinking biologically, probably I would go always with the collagen membrane first, because the long lasting of the LPRF membrane, probably it doesn't go more than 15 days. So this is the biological reason why I prefer to go first. Or maybe you can do a sandwich technique On top of the graft, you can put a layer of Alpuref. Then on top of the first layer of Alpuref, the collagen membrane, and on top of that, you can go again. So separating the effect for the bone and the effect for the soft tissue. But for me, the most important thing here of the Alpuref is the effect on the soft tissue healing. That is mandatory to have a nice healing of the soft tissue. Otherwise, you are going to have a nightmare.
Anybody else wants to take advantage to make some questions? Well, so we... Oh.
Professor Neves.
Thank you for the beautiful presentation of your lecture, but with the increase of vertical heights, do you ever consider soft tissue grafting as well, or you don't need to?
Well, it depends on the site. And of course, at the end, more than increase the height with soft tissue, I think, for example, in the lower joint, the posterior zone, the important aspect is the quality of the soft tissue. Let's say keratinized soft tissue. This is very important because if you have enough height, of course, of bone, I mean, you can go subcrestally with the implant and again use a 2.5 or 3 millimeters height of abutment. But to increase the height of the soft tissue, you could do it. In fact, there is some papers by Linkevicius where he tried to increase the height of the soft tissue. But probably you have to consider several factors. One is the final clinical crown that you need, and from the lower part of the clinical crown to the final situation of the implant installation is where you have to measure from instead of the thickness of the mucosa. But of course, you need at least 3 to 4 millimeters of mucosa height, but you can obtain it putting the implant subcrestally. 1.5 millimeters, and at the most 2 millimeters. Well, 2 millimeters.
Minimum.
Is the 2 millimeters rule.
Right.
Professor Blanco, do we have only allograft, not still the ionograft blocks?
Yeah, to my knowledge, today doing this kind of individualized blocks, only allograft. But why? Probably, well, I know that there is coming some research with Professor Sands and Professor Sasoi Ivanovsky from Australia, that they are going to introduce these new scaffolds, CAD-CAM made also, or individualized, custom made. Sorry? 3D printed. It's not a mill, it's 3D printed. So maybe they are a composite biomaterial made of bioceramic and polymers.
And do you think that there is any benefits to be allograft in terms of ionograft?
Well, the important thing here is that this material, regardless the origin of the material, is the structure. Is the structure by itself. The structure means that it needs to have the porous, the same structure as the hydroxyapatite of the human being. This for me is the most important thing. And to stay there for a long, keeping the volume of the defect. If you're able to have a biomaterial like that, it doesn't mind the origin where this material comes from, because the biology is going to do the rest of the work. You need to have something there to keep the space and the blood to come up to turn over that biomaterial independently of the origin of the material, can be an allogenic, can be an alloplastic or a xenogenic biomaterial, or an autologous biomaterial. All the biomaterials works in the same way.
Yes, but being allograft maybe can be inductor, not only conductor.
Well, it's osteoconductive. There is no, well, the allograft could be in somehow could be osteoinductive. This is the studies by Uris many years ago, but this was in this biomaterial that comes from the cortical part of the bone. So this probably after the sterilization process that they suffer, probably if they could have some osteoinductive cues, probably they lose them. But in my opinion, the important thing is to keep the space and to be osteoconductive. This is the minimum to allow the blood vessels to growth and to penetrate along these pores and along this similar structure that we have in our hydroxyapatite in our bodies. And with the time, remodeling.
Anyone else want to make?
Beautiful presentation, Professor Knott. The immediate implants that you place simultaneous to connective tissue grafts and bone grafts, the collagen membrane, do you find that there is an advantage to placing a collagen membrane between your connective tissue and the bone graft?
Thank you very much for the question. Certainly very interesting, and I have no answer really. I have only clinical feelings, but the evidence is to come. We are working on a randomized trial basically to assess if the membrane there, if there's a need for it. The filling and what other clinical expert groups do right now is just the xenograft or xenograft with collagen inside as a block and then the connective tissue on top without using a collagen membrane. Again, as we are inside the bony envelope, it seems that this is somehow protected. The other question is if we are truly looking for bone or just thickness. If we are truly looking for bone, then probably the membrane might make sense. Otherwise, the outer part of the biomaterial will be partially encapsulated into connective tissue. So, you know, it's an interesting topic, and we should do research on it, and we are doing it. So, yeah, thank you.
Thank you. I have 3 questions for Professor Nash. The first is that what type of membrane you use and how long is resorption time? The second is because we know that the tuberosity have a tendency of overgrowth and the issue with the color. And I see that in your case, you only try to make it thickness, it's not vertical. So this the reason why you choose the tuberosity. And the third is about the implant position. In the difficult case, we know that the implant position is the more difficult to make it. And you say that only for the experienced surgeon, it means the hand. But how about the digital guy? Is it have any benefit? And what the value of the guy and the hand experience? Thank you.
Thank you for the questions. I'll start with the last one. Yes, you also saw a case in which I used digital and a guide, and I think it's the standard of care today, being very honest. I would not raise a flap just to see. In fact, I don't raise any. So when I'm hesitating on my capability or when there's a real need on being exactly on the spot, I think the tools of guided surgery are there to be used. This is something we're doing in a routine basis in the department, and I do it myself, not as often as for the students, but I also use it. clinical skills and the learning curve is, I think, are shown to be important in immediate implant placement, but with guided surgery, you are really helped. Then regarding the membrane, as Professor Blanco is saying, I'm using cross-linked membranes for in cases where I'm not having a buccal bone. Okay, the durability when these are covered is described as for 4 to 6 weeks, and this is 6 weeks is the aim what we're needing. Some others are described up to 4 months, but entirely this is not a reality, and we know that as well. So ideally, if the buccal bone is missing, it's the only time I'm using a collagen membrane. This is cross-linked these days to me. And yeah, the tuberosity, certainly. We were quite afraid when we started dealing with these cases with a missing buccal wall and immediate implant placement, and we overcorrected excessively with tissue from the tuberosity. We've seen it growing over time, and of course generating a mismatching on the colors being too white, whitish. We've learned as well during these years with these days harvesting, depending on the concavity we might have, but this is a delayed scenario. There we go thick. For immediates, we're staying in a 1 millimeter, 1.5, less than 2 millimeters. Okay, then the color mismatching is not really seen. Okay, and you see, when we tested in a randomized trial palatal tissue or tuberosity tissue at 1 year, we didn't see differences more than the most apical part, which has nothing to do with the prosthesis. Okay, but the truth is that the palatal tissue was harvested very superficial. What it has to be is harvested. Okay, so it's a high quality from the palatal and high quality from the tuberosity. As I was saying, we are now finalizing the 5-year follow-up study, palatal tuberosity. From the pre-data, what I'm seeing is that there's only a tendency towards the tuberosity to be more stable over time, but we are not seeing overgrowth. The tissue from the tuberosity was harvested in the most superficial part, okay? And this might have something to do with these results. Thank you.
Any more questions?
At the end time, Professor Neves. To Dr. Ignacio Sanz Martin, beautiful research, beautiful cases. I would like maybe if you can give us some more insights about how you link your research with, for example, Sue and Gonzalez's publications on the critical subcritical contour. I think that we can come up with some links between the two research of you. They are somehow linked. I would like to, to discuss with you, or what are your thoughts about that? And on the tissue harvesting, honestly, I was not aware of your publication on the soft tissue graft and, palatal against tuberosity. And also if you see any benefits on having, more than the lamina propria going even further down and get the periosteum together to get further stabilization, to get further stabilization of the connective tissue graft when you place it in the site where we want to graft. So I want to, if you can give your thoughts about that. Maybe you don't have a research to back it, but clinical opinion would be really appreciated.
Thank you, Francisco, for your questions. Certainly good and smart questions. The first question was related to the concept of the critical and subcritical contour, which is mainly a prosthetic concept, in a way that, for those of you who are not familiar with it, basically says that once you put more volume of prosthetics below the area in the transmucosal zone, if you leave tissue, if you leave space, the tissue will grow. If you add material, whether it's acrylic or whether it's ceramic, that it will be pushing the tissue up, and it gives some very insightful ideas of how to manage the soft tissues. I think if we try to look for a link, I think the way that it touches with mainly the publication of the PhD thesis, where it evaluates different contours, different volumes of tissue, is that what we did is we tried to focus on analyzing the volume of soft tissue in the transmucosal zone, which is really the area that is most significant for in the cases that I showed for soft tissue. I wouldn't say stability, but I would say for soft tissue matching with adjacent teeth to mask the prosthetic components and to achieve optimal aesthetic results. You know, so this is clearly the region where it matters the most to have thickness and to have volume, and this is the area where we focus with our soft tissue grafts. So this is one part of the equation, the soft tissue thickness, and the other part of the equation is the restoration, and this is where the concept of the critical and subcritical contour come. And the other part of the equation is obviously also the bone, and the bone also plays a role in terms of volume, but in a more apical region, right? And this is what the research tells, and this is where the research shows who is responsible for which area in the volume, you know? So the bone is responsible for more the apical part, but the bone, what we saw is that doesn't necessarily correlate with the amount of soft tissue volume that you have in the transmucosal zone, particularly when the soft tissue thickness is already quite high, as we see in delayed implants. So these are a lot of concepts, intellectual concepts, but they really make sense, you know. And the other question that you were asking, the second one, remind me, I completely forgot. The periosteum and the way they integrates. So basically, the way the soft tissue graft, connective tissue graft integrates, it's not very different from the way, for example, a free gingival graft would integrate, which has different stages of integration. And the first is mainly through plasmatic circulation. There is neovascularization, and then there is graft maturation. So we cannot expect that the lamina propria is going to better, anchor with the periosteum. But what it does is precisely giving more thickness, giving more stability to the region, and giving more volume where it matters the most. You know, so I think that's why we primarily use it, and whether it is a tuberosity or a lateral palate that is being epithelialized doesn't matter. You know, the important part is that it's lamina propria, because this lamina propria is what helps to recover the volume that has been lost after extraction, and what we can use, for example, to compensate for physiologic resorption after tooth extraction, as Dr. Nutt showed in immediate implants. You know. So I don't think this could add, if you're asking for stability. If we want stability in posterior region, is mainly keratinized mucosa that we're looking into, and I think that's the concept. I would say. I'm not sure if I answer. I tried my best.
Okay, so one last question.
Yes, Professor Blanco. Is it make any sense that before or after put the block in place, inject some blood of the patient in the block of bone? Because
well, that is a good question.
Yeah, usually you can mix when it is not a block. You can mix the blood.
When you use this kind of biomaterials that are very dry, it's very important to use something to hydrate it, to hydrate this kind of biomaterials. Usually we use saline, and it's very important to have those materials hydrated. How can you hydrate these biomaterials? Of course, you can use blood. But in my opinion, there is not going to be any difference, because that blood probably there is not going to do anything, because the blood is going to disappear. So the key point, in my opinion, is to have that dry product very well hydrated before going to the defect. You can use the exudate of the LPRF membranes once you have the block fixed in the defect, but I don't have any data to say if this is well done or it doesn't matter. I don't have any data, but of course is, well, from a biological point of view could mean something, I don't know. But the key issue is to have the block very well hydrated before going to the mouth of the patient.
Thank you very much. Thank you very much to all the speakers for this magnificent session. I hope it could open your mind a little bit with all these new approaches and that you can take some tips to put on practice. Thank you again. Thank you, Anna, and enjoy.